education program on labor analgesia towards a safer, comfortable, and dignified birth. Labor pain is one of the most intense forms of pain experienced by women, and effective labor analgesia is an essential component of respectful maternity care. Today's CME aims to enhance our understanding of both pharmacological and non pharmacological approaches, recent guidelines, and multidisciplinary strategies for improving childbirth experience and outcomes. We are honored to have an esteemed panel of experts who will share their valuable knowledge and clinical experience. Without further delay, let us begin today's academic session with prayer song. May I now invite our respected Dean, Dr. D. Lakshmi Lalita Ma'am, and Academic Director and Medical Superintendent, Dr. K. Sudhi Sir, to deliver the introductory remarks and formally inaugurate today's CME. Yes, ma'am.
వెరీ గుడ్ ఆఫ్టర్నూన్. సుధీర్ సార్ నేను ముందు మాట్లాడేస్తాను, తర్వాత మీరు మాట్లాడండి. వద్దు వద్దు. థ్యాంక్ యూ. ఎనీవే, వెల్కమ్ యూ ఆల్ ఫర్ దిస్ వండర్ఫుల్ టాపిక్ ఆఫ్ ద డే, labor analgesia. So Revati ma'am is, I think, one of the pioneers, I should say, for everything. She's so energetic and so enthusiastic that she wants to choose the best out of everything, and she'll be after everyone to do this. And I really congratulate you, ma'am, with your team. You're really doing a good work. Now, I don't want to go into any of this labor analgesia and all, but one thing I can say is, it's always, they used to say it's a rebirth and all. We used to listen to so many stories of our grandparents and all, but nowadays have changed. Everything is what we want. So, a mother should be conscious and then welcome the baby without pain. That is what is the basic theme of the day, I think. So, I think maybe the days are changing so well that everything becomes very easy, and however we want, that is more important. In between the inverted columns, however we want, we try to get the best out of everything. And so, this is one of such types. And then if we start doing this at our institute and maybe we do it better, removing all the myths, like there were so many myths previously which we heard when we were students, that it's going to be a complication for the mother, for the baby, so many things they used to say, but I think all these are not there now. So without any of these myths, without any of these complications, if you start doing this practice, and maybe gems can go far better. And I think people should choose gems for what we are doing. I think it should be the best practice, and all the PGs should get benefited out of it, like how they learn and all. And I think with the guidance of Rati ma'am and Ramarao sir and Arvind sir, this is really going to happen very soon in a very big way. It's not just an intro, or it's not just a small topic, or it's not just for a few days, but it's going to be forever. So all the very best, and wish you all a very, very happy learning. And I request Sudhi sir to say a few introductory remarks.
సభకు నమస్కారం. మొట్టమొదటిగా డిపార్ట్మెంట్ ఆఫ్ ఆబ్స్ట్రిక్ అండ్ గైనకాలజీ అధినేతలు రేవతి మేడం గారు, అరవింద్, వీరందరికీ ముందు నేను కంగ్రాచులేట్ చేయాల్సిన అవసరం ఉంది. ఎందుకంటే దే ఆర్ టేకింగ్ ఏ వెరీ గుడ్ ఇనిషియేటివ్ టు మేక్ ది లర్నింగ్ more interesting to the students. మానవ జాతి ఇవాల్వ్ అవడం దగ్గర నుంచి, తెలిసిన దగ్గర నుంచి గత చాలా శతాబ్దాలుగా అందరూ ఎక్కువగా మాట్లాడే విషయం ఒకటే. నవమాసాలు మోసి తల్లి చాలా కష్టంతో, అతి కష్టమైనటువంటి కష్టాన్ని అనుభవించి బిడ్డకి జన్మనిస్తుంది. దిస్ ఈజ్ ఏ స్టాండర్డ్ స్టేట్మెంట్ ఎవ్రీ జనరేషన్, ఎవ్రీ హ్యూమన్ బీయింగ్ స్పీక్స్. That is the difficult part of a woman's life. Was the toughest thing for a woman's life. And I don't know why God has given that trouble to the woman, only woman. But the mankind has realized that the difficulty of a human woman, probably the evolution in the department of this evolution of this OBZ, I think you are bringing more comfort to the woman. That is the most important thing. This labor analgesia is nothing but a measure of giving some comfort to a woman in her toughest time. So అటువంటి ప్రయత్నాన్ని కోర్స్ మొత్తం ప్రపంచం అంతా చేస్తోంది. దాంట్లో మనం కూడా ఒక భాగమై, మీ డిపార్ట్మెంట్ కూడా దీని ఇనిషియేటివ్ తీసుకొని దీన్ని భావితరాలకి ఇటువంటి ప్రాక్టీసెస్ని అలవాటు చేయడానికి మీరు చేస్తున్న ఈ సెషన్స్ చాలా అభినందనీయం. అయితే ఒక్కటే నాకు చిన్న డౌట్. మన బిడ్డలు బిడ్డ తల్లిని చాలా కష్టపెట్టినప్పుడు ఒకసారి కోపానికో లేకపోతే ఫ్రస్ట్రేషన్తోనో 9 మాసాలు మోసి నిన్ను చాలా కష్టపడి కన్నాను రా అన్నారు అనుకోండి, రేపు ఈ స్టేజ్లోనే లేబర్ అనెస్థీసియాతో బిడ్డ కనబడి అప్పుడు రేపు బిడ్డతో తల్లి అంటే నువ్వు 9 మాసాలు మోసావు కానీ నన్ను కష్టపడి కనలేదు అంటాడేమో. ఎందుకంటే ఇప్పుడు అంతా లేబర్ అనెస్థీసియాలో బాధ లేకుండా కనేటట్టుగా చేశారు కదా అనే విషయం వాడికి, బహుశా మీ పిల్లలందరూ కూడా మళ్ళీ డాక్టర్లు అవుతారే కదా చాలా మంది. దే మే సే లైక్ దట్. ఇట్స్ ఓన్లీ బట్ మోస్ట్ అప్రిషియేటివ్ థింగ్, మోస్ట్ important evolutionary thing in the this obstetrics is this labor analgesia. This is I think hope this practice would attempt to carry on this knowledge to the next generation should go on. I thank you for giving me this opportunity to share my thoughts.
Thank you, madam, and thank you, sir, for your inspiring words and encouragement. Now I request Dr. Revati ma'am to kindly present a token of gratitude to Dr. Lakshmi Lalita ma'am. I request everyone to applaud. I request Dr. Sudhir sir to take our token of gratitude. To set the stage for today's discussion, I invite Dr. Arvind Sir, Professor of our Department Obstetrics and Gynecology, to take over, as Hemant Sir, our Medical Director, was not able to be here. Kindly applaud.
Beloved Principal, Medical Superintendent, HODs, OBG, Anesthesiology, Principals of Nursing College, Physiotherapy College, faculty, and my dear friends, on behalf of Dr. Hemant, I am delivering his presentation in view of his preoccupation with a high-level delegation, which is now taking place in our hospital. So, pointer. So, it is regarding why this buzz, um, not only in our hospital, but in all the circles where maternity is taking place. The buzz around labor analgesia is not merely about pain relief, it is about transforming childbirth into a safer, more dignified, and positive experience in GEMS, at par with the modern practices of obstetrics. As healthcare providers, our goal is not only a healthy mother and baby, but also a mother who remembers her childbirth journey forever with confidence, comfort, and joy. So, there are certain key issues to be addressed to ensure the mother in a comfortable stage. In fact, the journey of the baby from the mother's womb is considered to be the toughest journey in the world. So, uh, there are certain issues to be addressed to keep the mother in a comfortable state in during this toughest journey. They are related to the rising maternal expectations and positive childbirth experience. That is what is encouraged by all the professional bodies, including the WHO. And we have to address the problem of fear of labor, which is the major driver behind the escalating trend towards cesarean section. And the there is an imperative need to promote vaginal birth to enhance patient satisfaction and ensure modern evidence-based maternity care. It requires a multidisciplinary teamwork to ensure better outcomes for mothers and babies. And it is indeed a step towards compassionate health care and provision of comfort during labor is a hallmark of quality obstetric healthcare service. So, what are these changing expectations of the present day mothers? Today's mothers are educated, well informed, and empowered. They are increasingly seeking a positive and comfortable birth experience. And we all know that tocophobia, the fear of childbirth, is an important cause behind the increasing C section rates. And this problem can be well addressed with taking recourse to labor analgesia. So, labor analgesia addresses an important patient expectation. That's one thing. And all over the world, the current focus is on patient centered maternity care. modern healthcare is no longer about survival. It's not about, as Sir has just said, about Punarjanma. The safe mothers must be expanded beyond the prevention of morbidity and mortality and should encompass such fine things as kindness and compassion. It is more about safety, comfort, dignity, and a complete satisfaction, joy of motherhood. And this very fact is amplified by WHO in its advocacy through respectful maternity. All professional bodies, WHO, American College of Gynecologists, the Federation of Obstetrics and Gynecological Societies, NICE guidelines, and various professional bodies, European, Australian, they all say one thing. They emphasize labor analgesia as a key component of respectful maternity care. And we have to address this big problem of reducing, big problem of fear of childbirth. Fear of labor pain is a major reason for anxiety and elective C-sections, and availability of labor analgesia reassures expectant mothers. It also encourages the confidence uh, of a mother in her ability to undergo a natural vaginal birth. So there is every need to promote normal vaginal delivery because the C-section rate is abnormally high. Even in our institution also, the rate is so skyrocketing that it is much beyond the WHO safety limit of 10-15%. It is 5 times, 70 to 75% prevailing here. And effective pain relief can improve maternal cooperation during labor, and it helps reducing avoidable C-sections driven by fear of pain. And most importantly, there is a lot of concern and from the part of the government. It is seriously considering how to reduce the C-section rate. So it's rather an imminent need for us to think about this problem. And in this direction, the Karnataka government has already started labor analgesia as a routine policy to reduce C-section rates in Karnataka. Similarly, in Rajasthan, our Painless initiative should also support national and institutional goals of promoting safe vaginal births. So, another important need for labor analgesia being to enhance patient satisfaction. A satisfied client is the best ambassador for any institution. So, positive childbirth experiences improve hospital reputation, and a satisfied mother becomes a big ambassador for the institution. And it can certainly improve the trust in our healthcare services. That is to be kept in mind. And most importantly, it is a marker of advanced obstetric care. Ours is a teaching institute. Labor analgesia reflects multidisciplinary collaboration, and it speaks without saying, demonstrates availability of all that is required for modern obstetric care in the form of uh, specialists in obstetrics, anesthetists, pediatrics, and all other elite services. So it can position our institute among the prime quality-ridden, modern, and leading progressive maternity care centers. We can be one among them. And GEMS Hospital should emerge and forge ahead of all other healthcare institutions, being the first and the only facility offering painless labor in our parts. As a policy, there may be sporadic attempts to offer labor analgesia for a privileged uh, few, but as a policy, it is not being implemented in any of these parts, and more so in our state. So we can try for better maternal experience, better outcomes through labor analgesia, which can reduce stress and anxiety, which can lessen the maternal exhaustion, and ultimately it can improve the overall birth experience for mother and her family. And also important is that we have to align with the global recommendations of the WHO, ACOG, FOGC, ISA, and many other professional bodies. They say they support labor analgesia as a standard of maternity care, and represents evidence-based, compassionate, and modern healthcare in maternity. So we have to build a culture of compassionate care even in our institution also, because every woman deserves access to safe pain relief. That is what is being told by every organization and the civilized society. Labor analgesia symbolizes empathy in action, combines clinical excellence with a human-centered care. We have, in fact, all that is required to roll down this program of labor analgesia as an institutional policy in GEMS. We have a good clinical setup, infrastructure, fully equipped labor room with an exclusive earmarked dedicated place for labor analgesia. There are 2 suites made ready on LR concept, that is labor delivery and recovery in the same single setting. And we are being provided with 2 ultra modern labor tables, hydraulic, remotely operated, and we are privileged to be having a wonderful anesthesia setup. In fact, great many operations here are done through epidurals, and our postgraduates are also quite fluent and conversant with the procedure of epidural. Epidural setup, crash cart. I will take 5 more minutes. Crash cart monitor, CTG, radiant warmer, neonatal resuscitation bay, and all facilities for fetal maternal monitoring and safety are available right now. We're also getting 4 cylinders of Antonox containing 50-50 premixed nitrous oxide and oxygen, so as to have a facility of PCA, patient controlled anesthesia, analgesia, ahead of PCA. Now the current paradigm is PCA. So with our experienced faculty and trained PGs who are fluent in administering epidural anesthesia, I think the stage is set ready. And besides, we have a spectrum of alternative options for labor analgesia and to uh, avoid tocophobia. We have a wide spectrum of options making available to suit to the client choice and preference, both pharmacological as well as non-pharmacological, which can be act as complementary methods in the form of physiotherapy procedures like hydrotherapy, birthing pool, massage, TENS, birthing ball, provision of ambulation, movement, change of positions, Lemez, relaxation techniques, music therapy, and provision for a birth companion. So we have the required combat preparedness, having expert manpower, as it is a part of the fully equipped maternity OT. We have access for any emergency procedure at a minute's notice, like emergency LSCS or intubation. We have a fully dedicated round-the-clock working MCH team of specialists and postgraduates, OBG, anesthesiology, pediatrics, and physiotherapy. And our administration is taking steps to provide dedicated paramedical staff, skilled midwife, anesthesia technician to support the monitoring team of painless labor. And right now, what we are having is training, and already the dry run has commenced. We're having a series of CMEs and simulation workshops for training of all cadres, right from faculty to nursing cadre. And uh, and the best part of it is that as ours is a teaching institute where our postgraduates from the Department of Anesthesia, from the Department of OBG, from the College of Physiotherapy, they can be privileged to get themselves exposed and trained in the best practices of modern obstetric care. It's a boom for the postgraduates. Antenatal education and birth preparedness by a team of OBG, physiotherapy, and nutrition counselor are already underway in the OPD department of antenatal OPD. And we are currently in the process of developing systems, protocols, SOPs. The systems, protocols, SOPs for management of complications, checklists, inclusion and exclusion criteria, real-time partography, labor room guide policies, formats for consent, counseling and evaluation, they're in fact prepared. And very few are maybe in pipeline. We have to get the node of a nod from all the stakeholders. Social marketing for community awareness and demand generation are also underway. There will be a great launch by a VIP to mark the formal launching of the event. It is indeed going to be a milestone in the quality maternity care offered through GEMS Hospital. So the way forward being, we have to create awareness among ourselves, and today's CME is one step in that direction. And we have to buy in, the team buy in. All the members of the MCH team should own and work in synergy as a cohesive team to ensure success, strengthening collaboration between OBG, anesthesia, nursing, and physiotherapy departments, and most importantly, recruiting the complaints of the antenatals through education of the pregnant women and families to demystify the uh, various myths and beliefs surrounding labor analgesia. So we have to get ready to offer the most exciting and rewarding gift to the mothers of Srikakulam, since we are privileged, in fact, to set a new trend in women's healthcare in Srikakulam, all set ready to cross a milestone to implement labor analgesia as a policy in GEMS, which has to be made universally accessible to all the eligible parturients in this backward district at a very affordable cost. To begin with, at our medical director has quoted 1500 rupees, and our anesthesia department too has agreed only to bear the essentials of 1500 rupees per epidural, and to be enhanced to 3000 rupees at a later date. Delivery is, of course, in our facility is a 100% free of cost. And I conclude with the great saying of the famous obstetrician of all times, Moir. He said, delivery of the infant into the arms of a conscious and pain free mother is one of the most exciting, enticing, ecstatic, and rewarding moment ever remembered as an ever remembered pleasant experience in her lifetime. Yes, we can provide. Thank you.
Thank you, sir, for beautifully highlighting the importance of labor analgesia in modern obstetric care, dispelled common myths, and emphasize its role in improving the childbirth experience for women. Your expertise and practical perspectives have provided us with valuable knowledge that will undoubtedly influence our clinical practice. Moving on, we are grateful to have among us Dr. Shankar Sir, HOD, Department of Anesthesiology, Dr. Rahul Sheikh Sir, Principal and HOD, GEMS College of Physiotherapy. I request Dr. Arvind Sir to kindly present a bouquet to our distinguished guest, Dr. Shankar Sir. I request the audience to please give a round of applause. We are also fortunate to have among us the principal of Nursing College, GEMS. I request Dr. Sirisha ma'am to kindly present a bouquet to our distinguished guest, Principal of Nursing College, GEMS. Our next speaker, Dr. B.V. Sirisha ma'am, Associate Professor, Department of Obstetric and Gynecology. She will speak on physiology of labor pain and pain pathways. We request you to kindly take over, ma'am.
Good afternoon, everyone. So, my topic in today's session is about physiology of labor pain and pathways. So, it's a very small topic before jumping into the actual topic, labor analgesia. So, as I already said, labor is one of the most profound physiological events in a woman's life, and it is also associated with some of the most intense pain experienced by humans. And understanding labor pain is the first step towards providing safe, effective, and dignified labor analgesia. So, why is labor painful? Before understanding labor analgesia, it is important to understand why labor causes pain. And as we all think, labor pain is not just due to physiological factors, but it is multifactorial. And the three major contributing factors are physiological factors, psychological factors, and some additional factors are there. Coming to physiological factors, it is labor pain is caused due to uterine contractions, cervical dilatation, and perineal pressure. So what happens during each contraction? There is compression of the uterine blood vessels, which leads to transient myometrial ischemia, because of which there is release of inflammatory mediators like prostaglandins and bradykinins, which cause activation of the pain receptors. And along with the uterine contractions, there is also simultaneous cervical effacement and dilatation, which cause stretching of the mechanoreceptors in cervix and lower uterine segment, which both together, all together cause activation of the pain receptors, and from there pain impulses are carried by the nerve fibers. So coming to the second factors, like psychological factors, the pain of labor is increased by fear and anxiety of the patient, and also the support she receives during the labor. And additional factors like abnormal fetal position and intrauterine infections and any pathological factors, say for example like placental abruption or any high risk factors, will increase labor pain. So we should understand that labor pain is not just a physical thing, but it is also emotional experience. Coming to the adverse consequences of labor pain, because of the pain, there is increased catecholamine release, which causes activation of the sympathetic nervous system. And there is increased oxygen consumption, increasing the maternal work of breathing, leading to hyperventilation, and finally leading to hypocapnia and respiratory alkalosis. And there is increased cardiac output, and blood pressure also can increase. And there is delayed gastric emptying and decreased uterine blood flow, which affects placental perfusion, and thus it affects fetal oxygenation, so which can lead to even fetal hypoxia and respiratory fetal distress. And labor pain can also lead to incoordinate uterine contractions and prolonged labor. And psychologically, postpartum also, this pain can cause postpartum anxiety, depression, and post-traumatic stress disorder. So labor pain is not merely uncomfortable thing, but also it can have significant maternal and fetal consequences. So effective labor analgesia improves not only comfort to the patient, but it also improves maternal and fetal well-being. So coming to pain physiology, pain is carried by specialized sensory nerve fibers. As you can see in the picture, the first two are A alpha and A beta fibers, which mainly transmit motor and touch sensation. And pain transmission is mainly occurs through A delta and C fibers. You can see in the picture A delta fibers, which are thinly myelinated and they conduct impulses rapidly and they carry short, well localized pain. And C fibers are unmyelinated fibers and they conduct impulses slowly and they carry dull, aching, and diffuse pain. During labor, especially in the first stage, pain is predominantly transmitted through C fibers. That's why the pain they experience during the first stage is usually diffuse and cramping. And in the second stage, the pain is mainly carried by the A delta fibers and to some extent by the C fibers. That's why the pain in the second stage is sharper and more localized pain. Coming to pain pathway, pain perception occurs through a sequence of events. And the first step is transduction. First step is transduction. A painful stimulus such as uterine contraction or cervical stretching is converted into electrical signal by nociceptors. And the second step is transmission, where these signals travel through peripheral nerves to the spinal cord. And the third step is modulation. Within the dorsal horn of the spinal cord, pain signals may be amplified, inhibited by neurotransmitters and endogenous opioid systems. And the final step is perception. So signals reach higher centers, including thalamus, cerebral cortex, where pain is consciously experienced. So pain is what brain perceives, not merely what uterus generates. So how does labor pain actually feel and where exactly does it hurt? Before knowing that, we have to know all the stages of the labor to understand the pain distribution. As we all know, first stage means from onset of labor to full cervical dilatation, and second stage means from full cervical dilatation to expulsion of the baby, and third stage means after delivery of the baby till delivery of placenta, and fourth stage is first 1 to 2 hours after delivery of the placenta. So first stage, the type of pain is visceral, which is diffuse, poorly localized, cramping and slow pain. And the origin is mainly from the uterus and cervix, which is because of dilatation of the cervix and distension of lower uterine segment. And these uterine contractions cause stretching of the cervix, which cause activation of the mechanical receptors and followed by release of the pain mediators. And from there, pain generates and transmitted by the nerve fibers. So first stage pain mainly carried by the C fibers through the nerve roots T10 to L1 to dorsal horn of the spinal thalamic tract, from there to thalamus, somatosensory cortex, hypothalamus, and limbic system. Second stage, the type of is mainly somatic pain, which is sharp, localized, fast, and visceral pain mainly. And the origin is mainly because of distension and traction of the pelvic and perineal structures. Stimulate the myelinated rapidly transmitting both A delta fibers and C fibers. So pain impulses travel predominantly in second stage through pudendal nerve and enter spinal cord via S2 to S4 nerve roots and from there to spinothalamic tract and thalamus and somatosensory cortex. So in short, regarding the difference between first stage and second stage is mostly visceral pain, second stage is somatic pain. The pain in first stage is mainly due to the lower uterine segment and cervix dilatation, and second stage mainly the involved organs are vagina, pelvic floor, and perineal stretch. First stage pain is diffuse and cramping. Second stage is sharp and localized. And the main pain fibers involved in first stage is C fibers. And the nerve roots are T10 to L1. Second stage, A delta and C fibers both are involved. And the nerve roots are S2 to S4. And first stage sympathetic pathway is mainly involved. And second stage pudendal nerve. And coming to distribution and intensity of pain during each stage of the labor and delivery. In early first stage, you can see in the first picture, pain over lower abdomen and lower back due to uterine contractions, distributing to T10 and to L1 areas. And you can see in the B picture, late first stage, pain becomes more extensive in the same intense in the same areas as the dilatation progresses. And early second stage, you can see in the picture C, where the pain extends to the vagina and perineum as fetal descent occurs. And during delivery, the maximum pain is concentrated over perineum because of stretching of the pelvic floor structures carried via pudendal nerve. S2 to S4 routes. So knowledge of these pathways helps us to select appropriate analgesic technique and understand the extent of neural blockade required and predict the effectiveness of different regional blocks and manage labor pain while minimizing maternal and fetal side effects. Thank you.
Thank you, ma'am, for your excellent presentation on pain pathways. Your ability to simplify and beautifully explain the complex physiology of pain made the session both informative and engaging. Now I request Dr. Shankar sir, HOD of Department of Anesthesiology, to kindly present a bouquet to Dr. Sirisha ma'am. I request the audience to give a great round of applause. We now invite Dr. R. Arvind sir, Professor, Department of Obstetrics and Gynecology, to speak on position of labor analgesia in India, recent updates and guidelines. Sir, I request you to kindly take over and share your valuable insights.
Hi, friends. Without much uh, without much ado, let us move to the topic. Uh, we have to understand that the journey of the fetus through the mother's pelvis is said to be the most hazardous of all journeys, and we have to address this. And as told by my colleague, labor pain is one of the most acute resultant of a multifactorial origin, and it is exclusive for the mother. It is multifactorial in the sense that it has got a physiological basis, psychological basis, cultural and emotional components. Much is added to this pain. And the present modern practice do recognize that effective analgesia is a part of patient-centered safe birth. And effective analgesia can enhance maternal comfort, satisfaction, and quality of obstetric care. So here, hitherto, much feared about the safety of the mother and child, the present day trend is to balance efficacy with maternal and fetal safety. So there are, this is not new. Various attempts for provision of labor analgesia has been made from time to time, in fact, from time immemorial. In the ancient past, opium and natural analgesics were given to relieve pain, and it is Simpson who first administered ether in 1847 to uh, have a painless labor experience, and the clergy of the 19th century was very much against giving pain relief for a parturient mother, saying that the it is a curse to the woman. So, so it was not made available, but it is Queen Victoria who had preferred to have labor analgesia, and thus paving the way for access for labor analgesia for the rest of the people. So we must be thankful to Queen Victoria. She is the first woman to opt for labor analgesia, and somehow the fundamentalists had agreed to facilitate. Then the first caudal epidural came in 1916. Today, after from 1980s, patient-controlled anesthesia, combined spinal epidurals techniques are widespread, and the current trend is towards low-dose neuraxial, programmed intermittent epidural bolus, or so-called PIB, EB, PCA, and opioid sparing. So, pain relief is an important component of modern obstetric care and can be produced by neuraxial, systemic, or inhalational analgesia or through various physical techniques. Over the past decade, the availability of safer local anesthetics, ultra short acting opioids, combined spinal epidural needles, patient controlled analgesia and devices, and ultrasound guided interventions have revolutionized obstetrical regional anesthesia. So, why labor analgesia? I need not elaborate much. Labor pain is about the worst suffering that can afflict mankind. It is considered as one of the strongest pains a human being experience. It amounts to severing a limb, amputation of a limb on, without giving anesthesia on the pain intensity scale. With preparation, with antenatal preparation, it will be 30%. Without preparation and proper counseling, it will be still higher, 40%. So it is only humane to give pain relief to every parturient, and no woman should be denied pain relief in labor. It is the right of every woman to expect pain relief from her attending obstetrician, and the physician is also bound by the Hippocratic oath to provide cure, relief, and alleviate human suffering. That is what the Hippocratic oath says. Uh, all the professional bodies, including the American College of Gynecologists, American Society of Anesthesiologists, they do affirm by their profound declarations, labor results in severe pain for many women. There is no other circumstance where it is considered acceptable for a person to experience untreated severe pain, amenable to safe intervention while under a physician's care. But that happens for the great majority of the parturients. So they have clarified and declared without any confusion that maternal request alone is sufficient for and acts as a medical indication for pain relief during labor. Uh, there are various labor analgesia options, including non-pharmacological, pharmacological, including inhalational, systemic, and regional techniques. And what is the current state of affairs in our country? As of now, India doesn't have a nationwide program to provide painless labor. But several states and institutions are actively pushing labor analgesia to reduce C-section rates and make normal delivery less traumatic. It is Karnataka government which took the first governmental initiative. It has conducted a study, pilot study at Tumukuru, and found that the fear of labor pains was a major factor pushing women to C-sections. So the options proposed to decrease C-sections being epidural injections and nitrous oxide. And the health department there has already planned and implementing labor analgesia as a policy in all the government hospitals where facilities are available to curb the escalating C-section rates, which were almost more than, by now it must be more than 47%. So here the goal is to reduce surgical births and reduce maternal risk. And followed following Karnataka, the Rajasthan government is implementing a United Nations um, um, population uh, development backed midwifery program, wherein it promotes alternative birthing positions like sitting, squatting, and having a birth companion, virtual reality methods, and personal midwife care. They are being used to give women more control and to ease pain. Here, the focus is on respectful maternity care plus non-pharmacological pain management. VR methods and having a birth companion throughout labor for emotional as well as physical support uh, are expected to bridge the clinical care with personal support. And PGA Chandigarh is a whistleblower. They are conducting many national level workshops. And as of now, what is being actually used for painless labor is that the most common technique is epidural analgesia with bupivacaine plus or without fentanyl. That's what most anesthesiologists across India use. And there are other non-drug options in the form of Fentanox, birthing positions, companions, and VR, which we are shortly going to be dealt with by the uh, so ultimately the push behind the uh, current paradigm of consideration for painless labor is escalating rates of C-section. Uh, as we have just being discussed, the present C-section rate is crossing 50% mark versus the safe limit of 10 to 15% proposed by the WHO. Here, the fear of labor is the main driver. Now, uh, the modern woman is also coming forward with a demand for natural birth, preferably avoiding addressing avoidable pain. So, various studies have shown that 50% of women would opt even if the cost is high. And most importantly, labor analgesia helps avoid deviation from normal obstetric course. It mandates a standardized protocol and a, a, a big net of safety, because we will be privileged to have the presence of a life-saving anesthetist beside her. So the safety of the mother and the fetus is thus guaranteed. But still, there are many barriers. Most important is to create awareness. Many parturents in India don't know that labor analgesia exists. There are several myths around epidurals, particularly about backache, and there are shortages of manpower, in particular anesthesiologists for round-the-clock coverage, and access gap. Hitherto, it is confined to the privileged few, and there is a big requirement for training. However, the trend is clear, linking painless labor to reducing unnecessary cesarean sections. The Karnataka model has already is in place. So, alternatively, midwife-led care plus standby availability of epidural is a dual strategy. And our Indian Society of Anesthesiologists do affirm a team approach comprising of the anesthetist, obstetrician, physiotherapist, and NICE, all to undergo training together and work together. And by training the labor nurses for managing epidural infusions under supervision, and here even every anesthesia organization has emphasizing about low dose regimens like 0.125% bupivacaine plus fentanyl to avoid motor block so that mother can push, so-called walking, moving epidural. And there are these these professional bodies have laid down certain inclusion criteria and exclusion criteria, and has also underscored about the contraindications. I think these things can be well dealt by our anesthesia colleagues. But for mere mentioning, we can include all pregnant women willing for labor analgesia with informed consent if they don't have any contraindication. If they don't have any contraindication, particularly in cases of singleton pregnancy, term gestation, cephalic presentation, and if the woman is already in active phase of labor, crossing the 3 to 4 centimeter dilatation, but cervical dilatation is not a bar for labor analgesia. And age group can vary. Uh, Most importantly, we should confine to the ASA category, grade 1 or grade 2 parturients, low risk category with stable maternal vitals, reassuring fetal status, normal CTG, and the BMI is also within normal limits or just overweight. And exclusion criteria is, most importantly, patient consent is mandatory, refusal to consent, APH, severe preeclampsia, eclampsia, HELP syndrome, coagulopathy, thrombocytopenia, local infection at puncture site, allergy to local anesthesia, fetal distress, multiple pregnancy, malpresentation, previous major spinal surgery, deformity. These are mostly the for exclusion criteria. Contraindications, and most importantly, ASA grade 3 and grade 4 parturients should be avoided in the initial phases because they require the presence of experienced senior anesthesiologists and ICU backup. We can consider initiating beginning with low risk cases. And the standard operating protocol here is a one model. Indications have to be defined, contraindications also to be defined. Pre-procedure, there should be a review by the anesthetist and gynecologist. Check the HB platelet count. Valid consent should be taken. IV access with 18 gauge cannula. And for particularly for the category 1 patients, a preload with 500 ml of ringer lactate should be a safety precaution to avoid hypovolemia. We have to monitor the patient meticulously with for BP, SpO2, FHR, baseline vitals. Um, Drug regimens now everywhere it is low dose drug regimens, and we have to set the standards for maintenance. Monitoring is of utmost importance. Frequency, we have to watch for hypertension, high block, and fatal distress, and have to prepare SOPs for complication readiness. I think my anesthesia colleagues will deal mostly with these aspects. So finally, the international guidelines across the world say is women-centered practice. Dignity, autonomy, emotional health, and informed choice are paramount importance in intrapartum care. And informed maternal choice, a clear evidence-based info on pharmacological and non-pharmacological options should be given in the antenatal period itself, and there should be universal access, recognizing it as a right to access for labor analgesia, and no women should be denied pain relief if she requests it, and safe alternatives are available. And multimodal approach, there are many pharmacological and non-pharmacological means. It should be governed by the patient choice and safety. And WHO has recognized the limitations in low resource settings. Can be avoided epidurals in such places. And overall, there should be a holistic childbirth experience, and pain management has to be embedded in a broader framework to provide emotional support, communication, freedom of movement, and privacy. So, ACOG strongly favors epidural and modern low dose techniques, and it has proved beyond doubt. It has debunked a myth that it will enhance C-section rates. Extensive through its extensive RCTs and systemic reviews, that modern epidural methods do not increase cesarean delivery rates. In fact, can help in the reduction of the C-section rate. And they have also stated about the no dilatation threshold. Epidural must be provided on request, must not be withheld based on cervical dilatation criteria. And also, they have clear evidence to affirm that there is favorable neonatal outcomes after having labor analgesia, particularly neuraxial analgesia, low fetal dose drug exposure, no adverse effects on Apgar scores or neonatal outcomes. The dust has been settled. And finally, they do emphasize about shared decision making between the healthcare provider and the patient. Same thing envisaged by the NICE, and also by many other professional organizations, including European, Australian, Canadian societies. All guidelines converge on one single point of respectful maternity care and patient's autonomy, shared decision making, as well as patient's safety and comfort. So, uh, the present emerging trends in labor analgesia revolves around ultrasound guided neuraxial techniques, programmed intermittent epidurals, PIA, PIE beam, things like that, opioid sparing, opioid free epidurals, and novel neuraxial adjuvants and non pharmacological techniques, in particular, what is told in the WHO labor room guide in terms of respectful maternity. To conclude, neuraxial analgesia, particularly low dose epidural, is most effective, safe, does not increase C-section rates. The alternatives being Entonox, systemic opioids, and non-pharmacological methods, which can remain as valuable adjuncts. And there is a consensus about these guidelines, emphasizing informed choice, respectable care, and universal access. Key points here is individualized, evidence-based, patient-centric pain management to ensure best outcomes for mother and neonate. And uh, people have recognized the disparities and global gaps, and the future is very encouraging. Labor analgesia must be personalized, evidence-based, and incorporated into patient-centered care to guarantee the best outcomes for mother and newborn. Thank you.
Thank you, sir. Your talk provided a clear and comprehensive overview of the current status of labor analgesia in India, while effectively highlighting the latest evidence, recommendations, and evolving practices. The way you translated recent updates and guidelines into practical clinical insights was particularly valuable for all of us, sir. Thank you for the excellent and informative session, sir. Now I request Dr. Rahul Sheikh sir, Principal and HOD GEMS College of Physiotherapy, to kindly present over token of gratitude to Dr. Arvind sir. Moving on, it is my privilege to introduce Dr. Dasarapu Indrani, ma'am, MPT, PhD scholar, a distinguished academician, researcher, and clinician in the field of women's health physiotherapy. She currently serves as an lactation and natural birth specialist at Ankura Hospitals, Vijayawada. Dr. Indrani specializes in antenatal and postnatal exercise, labor and childbirth rehabilitation, menstrual health, female sexual health, and oncovaginal rehabilitation. She has published 16 research papers in reputed journals and serves as a reviewer for scientific publications. Her achievements include receiving recognition from the Asia Book of Records and India Book of Records for moderating a continuous 120-hour webinar featuring 240 physiotherapy speakers. She is also a university topper in both her bachelor's and master's degrees. Today, she joins us to share her expertise on the Painless Labor Initiative, an area where her knowledge and passion for improving women's health make her an exceptional resource. Please join me in welcoming Dr. Dasarapu Indrani ma'am with a warm round of applause. She will speak on role of physiotherapy and non-pharmacological approaches in labor analgesia. Ma'am, we request you to kindly take over.
Good afternoon. Thank you for the wonderful intro. Today, I would like to deliver about the role of physiotherapy and non-pharmacological approaches in labor analgesia. Impact of labor pain. One of the most intense form of pain experienced by the woman influences maternal satisfaction, increases anxiety and fear, may affect labor progression, can influence maternal and fetal outcomes. Goals of labor analgesia. See, pain reduction and anxiety control, improved childbirth experience, and safe mother and baby. This would be the major goals of labor analgesia. And physiology of labor analgesia. Cervical dilation. During the first stage, we experience cervical dilation, uterine contractions, lower uterine segment stretching. In the second stage, vaginal distension, pelvic floor stretching, and perineal pressure. Neural pathways, it's already we heard very clearly during the first stage, T10 and L1 and visceral pain will be perceived, and during the second stage, somatic pain, it's around S2 and S4 nerve roots. And this is the pain pathways usually women experience during the first stage of labor and during the second stage of labor. Fear, tension, pain cycle. See, I would like to elaborate more about this fear, tension, pain cycle. Mostly women experience intense pain during the time of labor. That intense pain is due to the uterine contractions. So uterine gives more major pain. That is only, I say, 50%. Major pain comes from the psychology or the by the thought, by the talk we make, by the move we do, and whatever the environment created around the mother plays a major role during the time of labor. See, there is a famous obstetrician, Sir Dick, gave a theory, Dick Reid theory. In this theory, the fear is the first. The fear makes the woman muscle tensed, and this also reduces the uterine efficiency. This uterine efficiency also increases the pain. Ultimately, the increased pain will give more fear. See, women already had a fear of labor. So if we are not supporting the woman during the time of labor, if we are not educating the woman during the time of labor, if we are not giving psychological support during the time of labor, women may feel even more intense pain during the time of labor. See, here the woman has lot of fear. The muscles will get tensed, and also the reduced uterine efficiency takes place. Due to that, the mother feels even more intense pain. If the pain is only 50%, and these all external or additional things makes the woman even feel more pain during the time of labor. So already fear, all the external factors affecting the mother will gives the mother even more pain perceived during the time of labor. So what to do during to reduce the pain as a physiotherapist? Physiotherapist can break this fear, tension, pain cycle. Let us see how it is. See, by mother has fear of pain. Her muscles are tensed. So first we'll deal with the tension relief. Relax the muscles. Make the environment cool. Teach the mother the breathing techniques. Calming breathing techniques utilizes patterns to focus and mind and release the muscle tension. If the muscles are not tensed, if muscles are relaxed, she may have proper uterine contractions during the time of labor. And the movement plays a major role during the time of labor. See, if you allow the mother to lay down, her back will hurt, all the pain will takes place, and mother keeps on lying down, and she's in a mood that something is happening to her, and something is bad going to her, or whatever the if see, normally, if you are not thinking anything, or mother is already having pain, making her to lie down and creating some buzz around her, oh, you are in labor, you are in labor. Apart from that, tell the mother, come out of that. Okay, you can walk, you can move, you can do whatever you want. This movement also plays major role in the time of labor. Utilizing the moments to aid baby's descent and promote the progress. See, if the mother is in lying position, the gravity won't help her. Progression may take place, but it is very less than when the mother is in the moment. So allow her to stand, allow her to move. This helps the this also helps the gravity to descend the baby, and also helps in the progression of the labor. Then manageable pain confidence. Talk to the mother before that how intense pain she has and what to do with that pain, how to cope with the pain. See, if the labor goes around 8 hours, 4 hours, or 6 hours, any whatever the time may be, she will not perceive the pain for 10 hours, 8 hours, 6 hours. Only the will be around only 60 seconds. You convince the mother for that 60 seconds, she'll be able to cope and have the pleasure of the pain. Pain. So talk to the mother. You have pain, but you can tolerate that pain. That is very simple. This simple talks and this simple education to the mother can be able to cope with the pain. So let us see how to cope with the pains and what are the non-pharmacological strategies we have in physiotherapy. Let us deal with it. See here, breathing pattern will helps the mother to reduce the muscle tension, and movement also helps in the progression of the labor, and deep relaxation techniques will help the mother to perceive less pain during the time of labor, and the knowledge about all this labor process will help the mother during the time of labor. See, role of physiotherapy in labor. Physiotherapy goals will be the pain relief, anxiety reduction, facilitation of labor progress, maternal empowerment, improved birth experience. Evidence-based interventions like education, breathing exercises, positioning, tense, massage, birth ball exercises, and hydrotherapy. In the antenatal education, most of the components will be the explaining the mother about the labor processes and pain management strategies, how to cope with the there are some breathing exercises and positional changes. Which position will help in the which stage of labor should be understood by the mother in the antenatal session, and partner involvement. See, mother, that may be the first time mother coming to the hospital, seeing some stranger people. Even though we are medical and well qualified, it may take mother to accept you all. So if we allow the partner in the labor room, that will helps in the mother to give some strength, some emotional support, as well as release of oxytocin during the time of labor. The benefits of antenatal education will give the reduced fear, increased confidence, better coping ability. See, this is the antenatal education. Some pain management strategies we can teach, and partner involvement. Educate the partner also during the time of antenatal education, how to cope with the pain experienced wife, how a husband can help his wife in the time of labor, what support he can give to her wife, is all we can explain during the time of antenatal education. And positionings, breathing exercises, and labor process. See, labor process may take place, but the contraction will remain only for 40 to 50 seconds, or the end it may be 60 seconds. If we convince the mother, if we give support to the mother, if we explain the mother about that 60 seconds, she will definitely will be able to cope with that pain. These are the breathing techniques. Slow deep breathing will be given in the early labor, and pattern breathing will be given the active labor. And this reduces the anxiety and improves oxygenation to the mother and enhances pain coping. Relaxation techniques like progressive muscle relaxation techniques. There are two types of progressive muscle relaxation techniques like Jacob and Mitchell relaxation techniques available. We can help the mother in relaxing during the time of labor, and guided imaginary, we can help the mother in imagining some kind of important or pleasurable things or pleasurable places she likes. These also we can do some mindfulness. We can explain the mother about the pain and some kind of meditation strategies before the time of labor. We can tell the mother, and effects decreases sympathetic activity, improves coping, and reduces perceived pain. These are the maternal positions like walking, standing, squatting, kneeling, side leg. This helps in the progression of the labor with the help of gravity, and improves the fetal descent, and also shortens the labor duration. Maternal positions, in this way we can allow the mother to sit, and in this way we can allow the mother to get relaxed in the labor room. Walking, standing, see, you can able to see. Active movement improves circulation and reduces tension. Uses and standing uses gravity and helps baby descend, and squatting opens pelvic diameter, aids baby passage, and kneeling relieves back pain, optimizing baby position, and side laying promotes rest, allows for monitoring. These are the advantages, and also shortens the labor. Birth ball therapy. With the help of birth ball, like some kind of pelvic tilts, pelvic circles, and rocking movements can be given to the mother to improve the pelvic mobility and reduce the back pain, and for better fetal positioning. These are the birth balls we can use during the time of labor. And birth ball can also be used as a relaxation position during the time of labor. With the help of partner support, mother can able to cope the labor by using the birth ball, by using the breathing techniques. Recommended exercises during labor: pelvic rocking and cat and camel exercises, hip circles, and forward leaning position. These helps in progression of labor as well as relaxing the mother during the time of labor. And gate control theory: non-painful sensory stimulus inhibit pain transmission. We can use tense as well as movement to control this pain. And electrode placement during the time of first stage will be around T10 and L1, and in the second stage it is S2 and S4. It is safe, non-invasive, and patient control. In evidence-based, these TENS mission reduces the pain scores and reduces the anxiety as well as maternal satisfaction. And it gives best result during the time of labor, and continuous application of labor. TENS can be used from starting to ending. There are more modernized TENS missions available in this modern area. See, this is the placement of the tents, and it is very easy to carry, and you can put in the pocket of the mother during the time of labor, and she can actively and easily can mobilize, can do all the exercises with the help of this pain. Tents reduces the pain, and this activity improves the labor and reduces the duration of the labor during the time of delivery. And this way she can go for squatting and all the moments. Hot pack application also helps in reducing the pain to some extent, and it relieves the pain, and it relaxes the muscle and improves the circulation by comforting the labor intensity. And hydrotherapy also plays major role to reduce the labor pain. The water helps in buoyancy activity, and it relaxes the muscle and reduces the catecholamines. And benefits of hydrotherapy are reducing pain and improve relaxation and less epidural also. See, there are many water baths available, like mother can be in the water bath till the end of the delivery or till the first stage. During the second stage, she can come out of the water birth also. There are different kinds of birthing tubs are available with the whirlpool effect, with hot water effect, and mother and this birthing pool also provides a kind of privacy for the mother, be in the water. That soothing effect relieves the back pain. The water makes the mother to feel light. There are a lot of benefits, and mother can be completely in the water birth, or as of what mother needs we can give with the help of this water birthing. And musical therapy also plays a major role during the time of labor. Instead of talking about pain and disturbing the mother about something else, you can give light music which feels good for the mother and which is liked by the mother. This reduces the anxiety and improves relaxation and positive birth experience. See, breathing exercises, this musical therapy plays major role during the time of labor process also. And aromatherapy, there are different kinds of oils which gives positive energy around the mother, and these oils also reduces the stress and improves emotional well-being. And this way we can put some candles and make the from from the olden days, instead of making some noise or something else, talking with the mother and talking about pain in front of the mother, you can create the environment very peaceful, also reduces the pain coping strategy near the mother. And virtual reality therapy, this reality therapy helps the mother to distract from that pain and causes relaxation of the muscles and improves the good experience. Emerging evidences of this virtual reality is reduced pain scores and reduced anxiety. This way you can give the mother some kind of stories or any kind of imaginary techniques, or whatever the mother likes, you can give input in that virtual reality things. She can actually lie down, she can actually sit, and whatever it may be she can do. And the recent current trend, the women are going through their birth journeys, that they are keep on searching in the social media, like what are the pain management techniques available in the social media. Each and every mother comes to me with a new idea, that in social media I have seen this, can I use this or can I use that? So the current trending pain management technique is like comb during the labor. See, mother holding a comb during the labor in hand also reduces some kind of pain, which the laboring mother squeezes a plastic comb in her palm so that the teeth pressure in the skin. The proposed mechanism are, this works under great control theory of pain. Pressure from the comb stimulates sensory nerve fibers in the hand. These competing sensory signals may partially close to the gate pain, signals traveling to the brain. Similarly, principles are used in massage, tense, acupressure, and counter pressure techniques. Distraction. This allows mother to distract. Something is in hand. Instead of thinking about pain, she might think that I have some weapon in my hand. So this comb may reduce the pain. So distract the mother from the pain, provide beautiful environment around the mother, and create some good positive environment. Allow the partner inside the labor room, may gives pleasurable labor birth experiences. See, this way you can allow the mother to hold a comb in the hand. Even mothers are packing the combs in their hospital bags also. I have seen many of the mothers getting the comb to the labor rooms. So clinical integration, mm, to complete all these non-pharmacological strategies, there should be an obstetrician, a physiotherapist, and midwife, and a nurse. The benefits of this team will be improved maternal outcomes, reduced intervention rates, enhanced patient satisfaction. See, by the end of my talk, I would like to conclude that labor is not a painful thing. Labor is a pleasurable thing. And we can make this pleasure to feel, and we can create a good birthing experiences to the mother. And modern mothers want this. I have experienced this kind of pleasure two times also. So we can allow the mother to feel the pleasure. So labor is not a painful. Labor can also turn as a pleasurable thing uh, in this modern medicine. Thank you for the opportunity.
Thank you, ma'am. We are truly grateful for the time and effort you have devoted to share your expertise with us. Your ability to beautifully explain and comprehensively present the various physiotherapy interventions and non pharmacological methods for labor pain management made the session both engaging and highly informative. Now I request Dr. Arvind sir, professor of our department, obstetrics and gynecology, to kindly present our token of gratitude to Dr. Indrani ma'am. I request everyone to give a warm round of applause. We will now break for tea for 10 minutes. Participants are requested to reassemble by 3:50 sharp for the remaining scientific session. Thank you.
understand and deliver effective labor pain relief. Okay, so here is my objectives. The first objective is pathophysiology of labor pain. The second is properties of ideal analgesic. The next, classification of analgesia methods, systemic opioids and delivery devices, and the safety profile and inhalational agents. So these side headings will be dealt in further slides. Okay. So already Arvind sir and Shirisha ma'am has dealt my half of the slides. Okay. So thank you for ma'am and sir. So I will start. So this is the pathophysiology cascade. Okay. Whenever a parturient or pregnant female offers a pain, okay, means when the brain perceives as a severe pain, then there will be a sympathoadrenal response will be there. Means there will be an increased catecholamines, cortisol and ACTH. This what happens makes a maternal woman to hyperventilate. So this, because of this, what happens? Carbon dioxide exhalation will be done, okay, causing respiratory alkalosis. Okay, once it is respiratory alkalosis, the compensatory metabolic acidosis will come. Okay, this metabolic acidosis, whatever the fatty acids, ketones, lactates, this will cross the placenta and makes the fetal acidotic. Okay, because of this acidotic and all, there will be an increased fetal oxygen requirement, making a fetal hypoxia. Okay, this is the pathophysiological cascade. Okay, so the next is, so this is what, how the pain perceived by the brain. This is three neuronal ascending pathway. Okay, here what happens whenever the noxious stimuli, okay, touches to the skin or anywhere, the mechanoreceptors, thermoreceptors or chemoreceptors will be activated and releases the chemical mediators. Okay, this chemical mediators activates this first order neuron. What is this first order neuron? For the pain, it is A delta and C fibers. Okay, A delta will be the sharp pain and C fibers will be the dull aching pain. Okay, this A delta and C fibers are the first order neuron. It ascends and it houses at dorsal horn of spinal cord. Okay, at this point, the first order neuron will release a substance P and glutamate. Okay, these are the excitatory neurotransmitters which activates the second order neuron. From dorsal horn of the spinal cord, the second order neuron will start and resides at thalamus. Okay, and from thalamus, the third order neuron will start and goes to the brain. Okay, cerebral cortex. This is the ascending pathway, and once the brain perceives the pain, then the descending pathway starts. Okay. So I will start this session. Okay, which drug we have to choose as an ideal analgesic? Okay, analgesic. So my objective is to achieve total sensory block, T10 to L1, while maintaining complete motor sparing. Why? Because of walking or moving epidural. Okay. So the next ideal should be to prioritize maternal and fetal safety. And next is preserve motor function and mobility. Patients should remain able to ambulate and maintain expulsive efforts for second stage pushing. Okay. And the next is rapid onset and surgical versatility, means provide predictable, fast acting relief that converts easily to full anesthesia if surgery is required. Okay. So that transition should be there. Likewise, we have to give the drug. So the methods of labor analgesia, the methods are classified into non-pharmacological, which is already dealt, and now it is pharmacological, which is systemic medication, inhalational agent, and regional techniques. So systemic medication by opioids, tranquilizers, and amnesia drugs, inhalational agents like Antonox, sevoflurane, and regional techniques, lumbar epidural, combined spinal epidural, paracervical, and pudendal nerve blocks. Okay. So we'll start. We'll navigate into the systemic analgesia landscape. Okay. First, when neuraxial techniques are not viable, we have to go with systemic analgesia techniques. The primary modalities are inhalational analgesia and systemic analgesia. So we have to monitor this analgesic spectrum, which is high efficacy and low monitoring burden. We have to balance and we have to do. Okay. So coming to systemic opioids. So before that, we have to know. Before that, we have to know once because of stress or anything, endogenous opioids will be released. Okay. How during stress the brain secretes its own analgesics, that is endorphin, dynorphin, enkephalin, which binds to opioid receptor throughout the CNS. Okay. Because of this release of endogenous opioids, what happens? Presynaptic block will be there and postsynaptic block also will be there. Presynaptic block means it stops the nerve fibers entering post by stopping the substance P and glutamate. Already I mentioned. Okay, the first order neuron will release, and from first order the second order will come. So this it really it terminates the substance P and glutamate. So by this stopping the presynapses, and next impulses will be lacking. And next is postsynaptic block, where it inhibits the second order neuron from sending impulses to the thalamus. So the brain cannot perceive the pain. So this is by endogenous opioids because of stress. But what the systemic opioids will do? They have three-level mechanism. The first is at supraspinal, next is at spinal level, the next will be at the cellular level. Supraspinal means these opioids binds to medullary receptors, okay, and then initiates the descending pathway. What is that? Off cells. That it initiates and blocks the pain transmission. Okay, this is at supraspinal level, which is at the medulla, and the spinal level, which is at dorsal horn of spinal cord at substantia gelatinosa, where there is a release of excitatory transmitters like substance P and glutamate. These are inhibitor. Okay, at spinal level. When coming to cellular level, you can see there will be the opioid will directly attach to G protein coupled receptor. Okay, and increases the CAMP levels. What the CAMP will do? This will alter the cell by increased potassium and decreased calcium. So this happens, hyperpolarization and excitability of the cells will be lacking. The pain will be reduced. Okay, this is how opioid acts. So why we are discussing about systemic opioid? What is the essentiality of reading the systemic opioids? Whenever neuraxial analgesia is not available, then we will go with systemic opioids. Okay, what are those? If any medical conditions like coagulopathy, severe scoliosis, or spinal any issues, abnormalities, where neuraxial is contraindicated, we will go with systemic opioids or other analgesia. And one more is medical and environmental barriers, where neuraxial analgesia are unavailable, we'll go with systemic opioids. And one more is patient choice and clinical experience. Some patients specifically prefer systemic opioids rather than this neuraxial. So in those cases also, we'll go with systemic opioids. So the clinical reality is systemic opioids, it causes dissociation of the reality of pain. It won't cut short the pain, okay? It dissociates from the reality of pain. So the next is the classification of opioids, okay? The pharmacological arsenal versus full agonist versus atypical. Okay, full agonist means they have a high affinity, and pure agonist, these agents provide total receptor activation for maximum effect. These agents are meperidine, morphine, dimorphine, fentanyl, remifentanil is also added. This is all purely full agonist. Mixed agonist, antagonist, and atypical. In this, there is a partial activation or mixed agonist antagonist action will be there. Here, the agents are nalbuphine, butorphanol, pentazocine, tramadol. These all comes under this mixed. Okay, so in opioids, systemic opioids, it is dose dependent. It is not drug dependent. Whatever the drug you are giving, it should be a dose dependent only. Whatever the complication, it is not drug related. Okay, and drug is also there, but it is least bothered. So we're starting with proper individual drugs. Okay, first focus on meperidine. It has an active metabolite. It reaches to the fetal, so we have to be careful. So most commonly administered systemic agent worldwide for intermittent bolus labor analgesia. It should not be continuous. Why? Because of this active metabolites as it accumulates in the fetus. So the critical drawback is its active metabolite has prolonged adverse effects on neonates. So this is the drug profile card of meperidine. It is widely used despite prolonged neonatal metabolite effect. Okay, its IV dose is 25 to 50 milligram, and if we have given IV, it is 5 to 10 minutes peak action, and duration lasts for 2 to 3 hours. Okay, it is historically it is used, but because of its active metabolite, it is less oftenly used right now. Okay, so the next drug profile card is morphine. Okay, so morphine provides potent analgesia but carries high neonatal respiratory risk. How? The IV dose is 2 to 5 mg and peak effect starts if it is given IV in 10 minutes and duration lasts for about 3 to 4 hours. Here, morphine has a fetal to blood maternal concentration will be more, and the active metabolites are very more in morphine. So it carries a high neonatal respiratory risk because of its active metabolite. Fentanyl relies on rapid redistribution rather than hepatic elimination. With IV dose of 25 to 50 mics, peak effect if it is given IV within 2 to 4 minutes, and duration lasts for half an hour to 1 hour. Okay, so it is more potent, which is 100 times more potent than morphine and 800 times more potent than meperidine. So it has a rapid tissue redistribution, which is 80% clearance will be there. But if we are given with a continuous doses or prolonged infusion, these accumulation will be more common. So the risk to the fetus will be common in fentanyl. Okay, if we are given repeated boluses doses or repeated infusions. So this starts. So right, remifentanil is the most common drug we are using. Okay, so remifentanil, which is ultra short acting mu agonist. Okay, pure agonist, which has an half life of 3 to 10 minutes. So this is by plasma esterase breakdown. So they have a minimal fetal accumulation. So if fetal accumulation is less, then fetal side effects are also less, which is compared with fentanyl. Fentanyl, which has 2 to 4 hours half life, so slower clearance than fentanyl. So because of this, fetal accumulations are much more common in fentanyl. Okay, so remifentanil, if we take the clinical side effects and monitoring, the side effects are compared with fentanyl and epidural. Okay, with remifentanil, lower fever episodes are seen, but compared with epidural, it is lesser. Okay, so fever episodes are seen in remifentanil, but it is which is 10% of cases, but in epidural, it is 37% of the cases. So fetal heart rate variability also, which has higher incidence of variability. So we have to keep on monitoring this fetal heart rate. Okay. And compared with other systemic opioids, remifentanil has a reduced resuscitation risk. Okay. So resuscitation monitoring and all should be must be there, but remifentanil it is lesser risk. So what is the clinical monitoring mandates? Okay, strict 1-to-1 nursing care should be there if remifentanil is given. Okay, and essential along with pulse ox capnometry should be there. Okay, so that any apnea detection like absent apnea or anything we can predict and we can do as necessary. So the vital sign elect thresholds are if respiratory rate less than 8 breaths per minute, if saturation less than 94%, or if apnea has been detected more than 30 seconds, we have to alert. Okay. So why we are more focused? What's the main thing is because of this placental transfer. Okay, what happens whenever opioids we are giving via IV or IM? Okay, what happens because of its high lipid solubility and low molecular weight? The transfer will be fast. Okay, it facilitates crossing and promotes diffusion. So once it is diffused via placenta to the fetal, what happens because of this rapid crossing, it causes transient reduction in fetal aortic blood flow and heart rate. So because of this, we have to constantly monitor fetal heart rate also while we are administering opioids. So the next is prolonged fetal metabolism. Because of immature hepatic metabolism and elimination, it causes drug accumulation which further leads to virginity, acidotic and all. So disappropriate CNS effects also will be seen because of immature blood-brain barrier allows opioid to exert greater effect on central nervous system. So we have to think about neuro behavioral depression to the kid also. Okay, drowsiness, this all we will be seeing in newborn also. So this is what rapid placental opioid transfer. So how to administer safely? This is very important, no? We got to know the opioid side effects and fetal accumulation and all, how to deliver safely. Okay, once the patient feels the pain, if we administer immediately, what happens? Once the patient feels the pain, if we delay the dose, what happens? That's the main thing, no? So we'll start. See, patient feels the pain and calls the nurse, nurses assesses and then pulls the meds, then administration, then patient will feels the relief. This is what happening. But if we cut short this calling and assessing, pulling the medication, this all, if we cut short and directly once the patient feels the pain, administration, patient pain relief. If we have done this, this is called patient controlled analgesia. Okay, here you can see patient feels the pain. Okay, and here he presses the button which is handheld. I will show you. And once that is done, pump delivers an immediate relief. This is the PCA pump, which is patient controlled analgesia pump. Okay, so that because of this pump, the pain weight interval will be reduced. Okay, so when to deploy this IV PCA pump? Okay, IV intravenous patient controlled analgesia pump, when to deploy? Whenever labor analgesia is indicated, first we'll get in our mind is neuraxial. That is a gold standard. Okay, so epidural is the standard of care, but some conditions where neuraxial is contraindicated in thrombocytopenia, coagulopathies, or spine deformities, there we have to deploy this. Okay, with IV PCA pump. Okay, so the main advantage is tailored administration and stable plasma drug concentration and less risk of maternal respiratory depression compared with bolus doses. Okay, with this PCA pump because of stable plasma concentration, drug concentration. So now comes, this is the PCA pump, right? In our setup, one PCA pump is there. We have already used to a live kidney transplant patient. Okay, it's within half day we have been removed also. It is an excellent pain analgesic when we intervene at beginning stage only. Okay, at beginning only if we intervene, it's a excellent. But constant monitoring should be there if we are giving systemic opioids. Okay, so you can able to appreciate here. Okay, this is the governing screen. Okay, and this is the reservoir, and this is what a handheld pump or handheld button will be there. Okay, this is the blue one. So here this governor which has a continuous rate, okay, which we won't set in labor analgesia, but the next PCA dose is there, the second one, which is the bolus. Okay, here we will set, okay, whenever the patient press, that amount of bolus dose will be entered. The next will be the lockout period. Okay, we will set that lockout period for about, like, that is our choice depending on the drug, 10 minutes, 15 minutes, or 20 minutes we will set depending on an individual or patient pain. Okay, so this will be set by us to prevent overdose or bolus doses. Okay, I will let you know how this lockout period works. So you can able to understand this is the patient controlled analgesia. The next, what's the advantages? It has a patient satisfaction. Why? Because keep on pressing, the psychologically they will feel like I have pressed, the drug has delivered, and they will think that my pain will be gone. So because of this psychological, this has a good patient satisfaction. And next, opioid consumption will be more, but it is a stable drug plasma concentration. Though it is more than what we have given, but though it has, sorry, higher total opioid consumption will be there at no significant differences in opioid related side effects. Okay. Next, nursing workload. It reduces acute pain call workload, but requires intensive setup, education, and monitoring. So the total workload remains neutral. Next, hospital operations, less cost effective than traditional dosing with zero impact on average length of hospital stay. We have already given, no, initially if we cut short that pain, that peak level won't be there. So we can reduce the length of hospital stay with this. So this is what PCA dosing reference regimen. Okay, with meperidine, bolus we have to set between 5 to 15 mg and lockout period will be kept between 10 to 20 minutes. Okay, I will tell you how to keep this lockout period and all, and when the drug will be delivered if the patient presses. So we have set at 5 milligram bolus and 10 minutes lockout we have set. Okay, we have set and we have given to the patient. Patient had a handheld button. Patient now at the third minute he is offering pain. I'm getting pain, I will press. He pressed that button. Okay, so this 5 milligram has been given to the patient. Okay, from there, the third minute to 13th minute, whenever he presses the button, the next drug will not be gone to the patient. Next 15th minute again he will press now. See, third minute he pressed, pain has been subsided little. 8th minute again pain came, so again he is pressing, but it won't deliver. Again after 10 minutes only, the drug will be delivered if he presses. So 8th minute he has pressed, drug has not delivered. 12th minute he has not pressed, drug won't be delivered. 14th minute if he press, again one more dose. From 14th minute, again 24th minute, that lockout period will be there. So between that, if we press also, it won't be, the drug won't be delivered, but we can able to see in the pump how many times the patient has been pressed. Depending on that demands, we can get to know how the severity of the score. Not only visual analog score, we can, based on this demands also, we can assess and we can titrate that lockout period and the dose. Have you understood? Or it is much more complicated? So further, in further slides, you might understand. So meperidine, it is bolus is 5 to 15 milligram. Lockout will be 10 to 20 minutes. We have to adjust depending on that. Nalbuphine, bolus is 1 to 3 mg. Lockout will be 6 to 10 minutes. Fentanyl, which is 10 to 25 mics. Lockout 5 to 12 minutes. Alfentanil is not used. Remifentanil is most commonly, that is 0.2 to 0.8 microgram per kg. Lockout, because of this ultra short acting, lockout will be 2 to 3 minutes. Okay. So why we prefer IV PCA pump? IV PCA provides rapid and patient controlled relief, but requires strict maternal and fetal surveillance. Okay, because of this rapid accumulation, we have to be careful. So rapid onset with patient autonomy. Okay, it provides direct systemic absorption and allows patient to self-administer within set lockout intervals. So remifentanil is the preferred choice because of its ultra short acting and rapid metabolism. So because of this, there is a minimized fetal accumulation compared with fentanyl. But there must be a mandatory continuous monitoring is required. Saturation, SpO2, EtCO2, and fetal heart rate monitoring should be mandatory. So monitor for respiratory depression of both mother and fetal. So this is very important. See, if we are given a PCA pump to a parturient woman, okay, because of this uterine contractions only this pain offers, no. So we have to guide her to press the button whenever she feels the pain. That is our motto to a parturient woman. So here what happens? See, uterine contraction will start. Started, it got a peak and then it has been subsided. If a parturient woman presses at the peak of the contraction, then what happens? Because of the remifentanil, it action will start after 2 minutes, no? So the contraction will stop and then the action will be starting. So if the patient presses the button at the peak of the pain, the drug peak effect completely misses the contraction. So arriving during the resting phase, which causes more side effects, okay, which accumulates in the fetus and causes much more side effect. So that's why we have to ask the parturient strictly trained to press the PCA pump at the very perception of contraction to align the waves. Okay, this is main important if we are placing remifentanil as a PCA pump. So visualizing the 2.5 minute delay to peak respiratory and analgesic effect. So we have done PCA pump, but this risk of depressions are common. So standard patient controlled analgesia empowers patient but lacks real-time physiological feedback. risking severe oversedation if respiratory vitals silently drop. So, because of this balance of analgesia and depressions are pretty common. So, something has to be done now. So, that's why they have done this vital sign integrated patient assisted intravenous opioid analgesic pump. Okay, which is our saturation and whatever it will be displayed. I will show you. So, this is what VPIA pump. Okay, here you can see the saturations and the heart rate, okay, which is incorporated. So you here, this is the hub, okay, where infusion pump has been kept, and this is the monitor where we can see the vitals and the boluses and all we'll be seeing, and the down you can see pulse ox and a handheld probe. That is what button will be there, and we'll press, okay. So this is what VPIA. VPIA means vital signs integrated patient assisted intravenous opioid analgesia. Okay, so it's the same as a PCA pump, but vital signs has been incorporated in this. Okay, this is a closed loop. Here, what happens once the patient demands? Once the patient demands, here the device, he presses the button, the drug will be delivered, and then here the signs whatever the continuous saturation heart rate and all will be monitored, and again the algorithm will open, again patient demand, again drug will be delivered. Before that, if any drop in saturation or drop in heart rate, this algorithm, what is this algorithm approach, it decides whether to stop or whether to send a signal to deliver the drug. I will show you the algorithm decision. The system either adjusts the delivery window efficacy or triggers an auto halt if safety thresholds are breached. I will show you. So this is what the breakthrough pain. This is a ladder. Okay, that lockout period ladder will be there. We will set it 5 minutes. For example, if we set it 5 minutes, if the patient more than two boluses has been delivered in previous 30 minutes, then the demands are more. He is offering more pain with these demands. So what happens? It decreases the lockout period by 1 minute. Okay, so it is moving the ladder down. See here, 5 minutes now we are set at this, but the patient is continuously pressing. In 30 minutes, it has been 2 times has been pressed. So it will enhance. It will only tell that patient demanding is more, so the lockout period should be less. So it will down the ladder. Okay. If any further thing is there, if the patient is requiring frequent dosing, the algorithm proactively shortens the lockout period to improve analgesic efficacy. So these are the safety breaks for VPIA pump. Okay, what is this? Does any saturation SpO2 less than 95% or heart rate less than 60 beats per minute, the system pauses the delivery. Okay, though they presses, but it pauses the delivery and checks the vital sign after 5 minutes. Okay, if it is resolved, if heart rate is resolved or saturation is resolved, then it increases the lockout period. The ladder will go up. If it is not resolved, the pump will stop. An emergency stop of saturation less than 90 or heart rate less than 50, the pump will stop permanently. So these are the automated safety breakups has been done. So for this VPIA pump, the BMC anesthesiologist trial also done for 19 patients. Okay, what regarding efficacy of pain relief versus incidence of oxygen saturation. Here, 19 patients they have been given trial. For 19 patients also there is an oxygen desaturation. One episode at least they had it since, but for the 14 patients there is a safety pauses has been seen. So the safety pause is there. So much more preventing the transient drop from becoming clinical emergency. Okay, and 1.9% they have been safely delivered. So this is what PCA pump versus VPIA mechanics. Okay, PCA pump, it is a fixed lockout interval. VPIA, it has a variable lockout. It ranges from 3 to 10 minutes. And monitoring, it is blind to patient vitals in PCA pump. And VPIA, it is highly response to saturation and heart rate. And system, it is open loop in PCA, closed loop in VPIA. A safety mechanism is incorporated in VPIA. Okay, so these halts and all. So coming to the differences, remifentanil, meperidine, fentanyl. Remifentanil has a highest analgesia and satisfaction compared with meperidine and fentanyl. And pain reduction is also good in remifentanil, but epidural crossover is more in meperidine. Neonatal resuscitation risk is more in meperidine and fentanyl compared with remifentanil. Okay, so remifentanil dominates traditional systemic opioids in efficacy and satisfaction, effectively minimizing the crossover to epidural analgesia. So this is a clinical atlas. I'm just skipping because of time lacking and all. Tramadol, which you have to learn. Tramadol IV dose will be 50 to 100 mg. Duration will be 2 to 4 hours. And tramadol has a dual action. Okay, one is weak mu receptor opioid and selective serotonin norepinephrine reuptake inhibitor. Because of this weak opioid action, it has less risk in neonates. So opioid antagonist, when we have overdosed or any respiratory depression you have been observed, then the first is you have to identify the trigger, and then you have to ensure heart rate saturation with a positive pressure ventilation. Okay, stop whatever the drugs you are giving and administer naloxone, which is 0.1 microgram per kg IV you have to give. How naloxone will work? Its onset start with 2 minutes and lasting for about 30 to 40 minutes. Okay, it's a pure antagonist. Directly it antagonists on mu opioid receptor. Okay, and doing its action. So what are the narrow safety profile drugs? So narrow safety profile drugs are benzodiazepines and ketamine. Benzodiazepines, diazepam, lorazepam, midazolam. Because of this massive half-life, these are absolute and we are not using in active labor. Okay, see diazepam, elimination half-life is 24 to 48 hours. Lorazepam, which is 12 hours. Midazolam, which is 1 to 4 hours. So these are not acceptable in active labor. So ketamine, which is a narrow niche in labor, okay, because of its rapid, highly effective analgesia for delivery, 97.5% success rate is there for complete analgesia because it is an NMDA antagonist which provides dissociative analgesia in less than 30 seconds. For about 5 to 10 minutes it acts. Okay, but it maintain mandatory continual verbal contact because of to monitor airway and ventilation, and strictly avoid in hypertensive patients because of its sympathetic response, increased heart rate and cardiac output. So pre-eclamptic patients we have to avoid. Not for routine first stage labor because of its narrow niche. It should be immediately before the delivery we can use. So inhalational agents, which is Antonox, so nitrous oxide, it's a gold standard for mild labor relief. Okay, but we have to know the Antonox rhythm. Okay, start inhalation at contraction, onset of contraction, so that the peak effect, which comes in 45 to 60 seconds, you can feel. Okay, it should be therapeutic blend should be 50% nitrous oxide and 50% oxygen. It's a weak anesthetic enhancing natural pain relieving peptide. Because of its rapid elimination, it has a minor side effects. So gas does not accumulate, but it causes nausea, dizziness. Otherwise, it is an excellent high satisfaction for the parturient woman. So nitrous oxide alone, it is higher satisfaction than epidural. So the steps, Antonox, it should be inhaled when we are anticipating a contraction, okay, which is very rapid onset due to low blood gas solubility. So in less than 60 seconds, it reaches the brain concentration peak, and then the placental transfer will be there. But the neonate also will be eliminated by neonatal respiration. So there will be a low risk and no effect on fetal heart rate, Apgar or cord blood gases by nitrous oxide. So the differences between remifentanil PCA pump and nitrous oxide is remifentanil has a greater absolute pain relief. Nitrous oxide is a quantifiable lower compared with this. But remifentanil has a significantly higher maternal sedation, higher overall patient satisfaction as reported by remifentanil. High risk of intensive monitoring is also by the remifentanil. But nitrous oxide, which has zero fetal heart rate changes, zero intensive monitoring needed, so it has benignly safety profile. Okay, so one trial also done. Participant prefers remifentanil for satisfaction, but accept massive respiratory risk. So nitrous oxide is not a potent analgesic, but offers unrivaled safety. So this is the other volatile agents: sevoflurane, desflurane, isoenflurane. Sevoflurane opts for the best because of its less irritating, less unpleasant odor, and very low pain scores compared to other. Summarizing, you're happy now, but still 6 more slides are there. You have to, and 5 to 10 more minutes. Okay.
Sir, your presentation is extremely crucial and important, and it is in fact the essential for today's day. So
Thank you, sir.
you are
Thank you so much, sir. So, because of sir's word, I'm like overwhelmed. I'm not getting any words also. Thank you so much, sir. So, based on the first stage, second stage, third stage, it will be going on. Okay. The first stage, most of the time, as Sirisha ma'am said, it's a visual pain. The next comes with the somatic pain. Okay. So, visual pain, most of the time, we will be going with Antonox or systemic opioids. Once it commences with the second stage, third stage, then the spinal rescue or somatic pain, if it is there, then the pudendal nerve block. But throughout these stages, epidural is the standard. Okay, T10 to S4 coverage. So effective analgesia is not a single decision, but a dynamic pathway matched to the ascending physiological intensity of labor. Okay. So this is what grand analgesia matrix, okay, comparing all the drugs, what I've dealt now. So systemic opioids, inhalational and neuraxial, based on efficacy, fetal impact, maternal side effects, and motor block. Systemic opioids are having high respiratory depression compared to other, and inhalational has minimal fetal impact. So I will read completely. See, systemic opioids efficacy is moderate. A fetal impact has high respiratory depression. Maternal side effects like sedation and nausea will be there, but motor block is not there. Inhalational Antonox, mild to moderate efficacy, minimal fetal impact. Dizziness, dry mouth is a common side effects. Motor block is none. Neuraxial, which is a gold standard with minimal fetal impact. Maternal having hypotension, fever, and depends on motor block will be depending on variable agents. So this is the clinical trade-off matrix. Okay, based on x-axis, it is a clinical monitoring burden and risk, and in y-axis, it is the analgesic efficacy, low to high. In this triad, main epidural plays a good role, gold standard, which is having high analgesia efficacy with low monitoring burden and risk. Okay, and the next comes nitrous oxide, which has less clinical burden, less clinical monitoring burden, and less analgesic effect also. But it is safe and mild. The next comes meperidine, which is moderate pain relief, high turnover to epidural. Ketamine, which is specific areas will be delivering this before delivery. And remifentanil, which has an high analgesic efficacy, but because of its intense monitoring burden and risk, it is on lower side. Okay, because of requires one-to-one nursing, it is on lower side. So neuraxial dominance has largely replaced systemic analgesia. See, you can able to appreciate here 1981, where 52% of participants has been given parenteral, then it has been slowly reduced. Sorry, it has been slowly reduced, and right currently it has been less than 25% also. Okay, but epidural, which has been drastically increased. Okay, now more than 70% it has been reached. So despite the overwhelming shift towards epidural use, systemic opioids remain a foundational clinical requirement across all hospital strata. So this has to be known. Why? Because to avoid complication, this systemic opioids and all you have to know. Okay. So take home messages. This last 3 slides, I will wind it off. So this is a toy. Whatever I don't know, please wake up. These last 3 slides, I'm just compiled. Okay. Thank you for waking up. So this is what systemic labor analgesia requires a balance between maternal satisfaction and neonatal safety risk. Okay, so we are starting inhalational methods offers high neonatal safety. So this nitrous oxide and volatiles show no reported adverse effects on Apgar score or fetal heart rate. So inhalational is best considering neonatal safety. Opioids carry universal neonatal depression. So all systemic opioids, you have to be careful while you are administering. And remifentanil requires one-to-one nursing vigilance. So whenever you see saturation drop or any respiratory rate less than 8, you have to activate the call. Next, some specific contraindications you are seen by ketamine and benzodiazepines. Avoid ketamine in hypertensive patients and benzodiazepines because of neonatal hypotonicity and impaired thermoregulation you have to avoid. So choosing the right systemic analgesia is very important when epidural analgesia is contraindicated. So use fentanyl for rapid short-term relief, okay, via PCA pump. If remifentanil is available, remifentanil we have to do fentanyl. So but you have to carefully, you have to monitor. Prioritize diamorphine nalbuphine for nausea. Because of this fentanyl, these all nausea vomitings are pretty common, then you have to go with the diamorphine nalbuphine. These agents provide longer lasting relief with focus on reducing maternal nausea. And the next is to protect fetal respiration and all with nalbuphine and butorphanol. So avoid mepridine if delivery is near because of its active metabolite. Do not use if delivery is expected in 3 to 5 hours due to peak normepridine accumulation window. So choosing the right drug at right time is very important in systemic analgesia. So the last slide, happy soul. So balancing act, precision in systemic labor analgesia, this is very important. Efficacy versus accumulation, safety and neonatal risk, these should be balanced. Okay, so balance rapid onset analgesia and against the risk of neonatal depression and metabolite accumulation. So you have to make sure you have to balance regarding analgesia and accumulation. And here near risks are dictated by prolonged half-lives and immature fetal blood-brain barrier. So treat them accordingly. Dose dependent should be monitored. So the labor PCA matrix, this is the end of the slide. Fentanyl, remifentanil, and epidural, I am comparing. See, remifentanil will have moderate to high speed. Remifentanil, which is very high because of its ultra short acting. Epidural, which is best and gold standard for labor analgesia. Thank you. So for the next gold standard epidural analgesia neuraxial, our Bangaram Srija madam is coming to deal with that. Thank you.
Thank you, ma'am. We sincerely appreciate the way you beautifully explained and comprehensively covered the topic. Your clear insights into management techniques have enhanced our understanding of holistic labor pain management. Thank you once again, ma'am, for your valuable contribution to the CME. Now I request Dr. Ramarao sir, Professor of our Department Obstetrics and Gynecology, to kindly present a token of gratitude to Dr. Shravanti ma'am. We now invite Dr. T. Srija ma'am, Assistant Professor, Department of Anesthesiology. She'll be speaking on neuroaxial techniques and management of complications of labor analgesia. Ma'am, kindly proceed.
Good afternoon. Slides. Yeah, I'm Dr. Tapis Rija, Assistant Professor in Department of Anesthesia, Jemson Hospital. Today I'm going to talk about neuroaxial techniques in labor anesthesia. So first of all, I just want you to tell about anesthesia. How many of you know about the history of anesthesia? Does anybody know? Here, I think our first years should know this. So previously, before anesthesia is there, they used to hardly perform only 3 procedures. Okay, which is amputation, tooth extraction, and one more is some appendix or something, by just tying the patient around in the corner in the bed and just extracting it. So the way anesthesia has improved, it made a lot of efforts actually are been taken so that the surgical branches kept on improving. And now we are doing thoracic procedures also because of the extent of the anesthesia's improvement in anesthesia. Okay, and previously actually pain was considered as sin. It was considered like pain should be tolerated. It is sin given by it is a religious concept actually, that pain should be tolerated and it should not be taken into consideration. But thereafter, as anesthesia has improved its roots and it has deepened into it, now the perception of the pain and the pain consideration is still more improving. And anesthesia is considered as the biggest blessing to the let's say the surgical departments actually. And then labor analgesia is still considered because we have dedicated anesthetists to this labor who are obstetric anesthetists who are dedicatedly trying to improve the labor analgesia concept here. So this neuraxial techniques you can see here in the background. The parturient who has come for the labor is taking a neuraxial technique. Now let's see who is listening here. What is the primary indication of the neuraxial technique? What is the first initiation point? Somebody should answer. Please wake up. What is the first point? Indication, most common point when you should initiate neuraxial technique. It is soul and soul maternal request for pain relief. Whenever the parturient asks for pain relief, that is the point where you should initiate the neuraxial technique and labor analgesia. Okay. This is very important topic. So many obstetric anesthesiologists have used so many modalities and they are being still used the modalities to provide adequate pain relief during labor. But it is considered that neuraxial analgesia has been considered as a good standard as it's proven efficacy and also flexibility with maternal satisfaction. However, we need to emphasize that most non-neuraxial methods, they do not provide complete pain relief, but still they do allow the woman to cope up with the pain, okay, during the process. So I just do brief it because for so times this slide has been repeated. I think all of you might be getting bored. There are in the 3 stages of labor. Why this slide is important is we have to know which level has to be addressed for which phase of the labor. Okay, for example, in the stage 1, in the initial latent phase, parturient will not be feeling so much of pain. Okay, it just they will have a dull aching pain which need not be intervened. Intervention might not be necessary for all the patients, but it is subjective to pain. Okay, all patients are not the same. They are subjective to pain, so we must consider even if the patient is in latent phase of labor. Active phase of labor, usually it starts from 2 to 4 centimeters of dilatation, and then the duration varies from 2 to 6 hours. So what happens in the active phase, as so many times it is repeated, it is due to the uterine contraction and cervical dilatation, the patient is feeling pain. So here, when it comes to the visceral pain is always starting from the uterine contraction and cervical dilatation. It is mixed with the sympathetic fibers and the levels activated are T10 to L1. So what levels have to be addressed in the neuraxial technique in the active phase of the labor? It is T10 to L1. So later on what happens due to the fetal descent and stretch in the pelvis and due to the pressure sensation, patient will be having somatic pain from the cervix, passes through the pudendal nerve and the sensations will be passing through sacral nerves, S2 to S4. They will go through the ascending pathway. I don't know this point is working or not. So this passes through the ascending pathway, it reach the thalamus. From thalamus, they will be going to all the directions like cortex and also cardiorespiratory fibers and limbic system. And from there, the woman will feel perception of the pain, and from there, the descending pathway starts. So this is what, in brief, to explain about pain. So in the active phase, which all segments have to be addressed? It is T10 to no S4. Is it mean in the late active phases and in the stage 2, what all have to be addressed? Till S4 till S4 it has to be addressed. Otherwise, patient will not be having any pain relief. So how do we address that? We'll see it in the later slides. The ideal characteristics of labor analgesic, we should know the first and foremost important idea is maternal and fetal safety and ease of administration. Then the analgesic should be consistent, predictable, and rapid in onset. The maternal composure and control should be there during both first and second stages of labor. Analgesia should be there throughout all the stages of the labor. There should not be any motor blockade in order to make the patient ambulate in the various birthing positions and preserve the stimulus for the expulsion. So the contraction should be there, stimulus should be there, and the patient should be able to expel. Expulsive effort should be there. Okay, and in order, if we want to give any additional analgesic, we have to be able to provide without doing any other invasive procedures. And also, if that is failed and if the patient ends up into C-section, we have to able to convert the analgesic method into anesthetic procedure. So we need not do any additional general anesthesia, or we need not perform any additional procedure. So if the patient usually ends up into C-section. These are the ideal characteristics. Okay, so now I am going to talk about the into three parts actually. One is technique, type of the neuraxial technique. The othermost thing is drug. Okay, so drug also we are going to divide it into two parts. It is loading. Initially we say it as charging of the catheter. Then after charging, we have to keep the patient under maintenance. Okay, so those are two components of a drug regimen. So now we'll see it in detail. These are the indications and contraindications. First and foremost indication is maternal request for pain. The other indications are depending on the type of the neuraxial technique. Okay, depending on the type of the neuraxial techniques, indications keep on changing. Contraindications are divided into absolute and relative contraindications. Absolute contraindications are obviously coagulopathies, infections, raised ICTs, allergy to local anesthetic drugs, patient refusal, which is very, very, very important. Patient refusal. Relative contraindications are pre-existing neurological diseases, fixed cardiac output states like mitral stenosis, severe anatomical deformities of spine, thrombocytopenia, and if patient is on any prophylactically low dose of heparin therapy, and few uncooperative patients. These are all relative contraindications of neuraxial technique. Now I will show you, this is the longitudinal section of the spine. Here you can see the vertebral bodies, and these are the spinous processes, and this is subcutaneous tissue. So there are three types of techniques here. If we go and insert the drug into the epidural space, this is called as epidural analgesia. Now we have to talk only analgesia because anesthesia is numb. There should not be any numbness. There should be only analgesia. So if you give drug into the epidural, it is called as epidural analgesia. If you give drug into the intrathecal space, spread will be through CSF, and so that is called as spinal analgesia. And one hybrid technique is there where we are going to use both spinal and epidural, which is called as combined spinal and epidural. So I wanted to, this is prepared by me. I'm so happy that to tell that this is prepared by me actually. So this is a cross-sectional view where in the epidural, actually, if we give the drug, it is called as epidural spinal. So if we give drug in both epidural and spinal, it is called as combined spinal and epidural. Another technique is there where it is called as dura puncture epidural, where we go puncture the dura, but we do not give any drug into the CSF. We just give the drug into the epidural. Then why to puncture this dura? That I'll tell you in later sessions. Okay, so first let me tell you the basic difference between spinal and epidural so that we'll proceed to the later slides. So in spinal, usually what happens? We give drug into the cerebrospinal fluid, and cerebrospinal fluids move from place to place. So we will not be having any control over our drug. So the extent of spread will be from thoracic to sacral. Understood? So if we talk about epidural, epidural is always segmental. So it always happens in the segment. So if you want to block thoracic, you can only block thoracic. Lumbar, lumbar. Sacral, sacral. So that's how it's going to work. So epidural is always segmental. Spinal acts very fast. It acts within 3 minutes. Epidural takes time. It takes 15 to 20 minutes to activate the epidural. So this is the basic difference. Now I'm going to tell you differences in the procedures. One is single shot spinal analgesia. In the single shot spinal analgesia, as it is, as the name suggests, we only give a single shot where and our main goal is to provide only analgesia. So we are going to only give more dose of opioid with less dose of local anesthetic. Now this is not the same as we perform in our OT. Okay, in our OT, we are going to take larger doses, larger volumes of local anesthetic. In the labor, what we are going to do, we are going to only provide analgesia. So that is the reason we are going to give 25% of the dose from the spinal. So only 2.5 mg of bupivacaine with the fentanyl. This is not hyperbaric, this is isobaric, sorry. So here we are going to use only isobaric with opioid into this. And definitely this comes only for 4 hours and it weans off. But no, then why is this procedure useful for? It is useful in the patients who are very severely having contractions and they are not coping up with they just want to end up into C-sections. So for those patients, we can counsel the patient and we can tell them in the single shot it will be over. And this is done in low setups, like if the setups where we cannot put epidural and we cannot manage the patient, there we can use these procedures. These procedures are being used in Philippines more commonly. Next is continuous spinal analgesia. In this continuous spinal technique, as the name suggests, it is continuous. So what do? We put a epidural catheter, which is pediatric epidural catheter. Usually it is 24 gauze catheter, which we insert it into the CSF. And then we provide continuous medication with that epidural catheter. But the main concerns about this is patients might end up into cauda equina syndrome. Okay, which is, and I will tell you, as this there is no control over spinal analgesia. The adverse effects of this would be hypotension, total spinal, complete spinal. Because of the hypotension, patient might end up into fetal bradycardia, and also so many other adverse events might be there if we use spinal analgesia. Next, coming to epidural, I told you epidural will always provide segmental block. So this can be activated in the latent phase of the labor, and then it can be used for the active phase of labor too. So here the concentration of local anesthetic usually is very, very low dose. It is 0.0625% of lignocaine, bupivacaine to 0.125% of bupivacaine. And we most commonly use additive along with this, which is fentanyl or morphine. According to the patient's needs, we can mix up the fentanyl with this. Usually it would be 2 microgram per ml. Combined spinal and epidural. So this is epidural analgesia, where we will thread the needle through this epidural syringe into the epidura and then to the epidural space, and then we provide continuous analgesia through this. This is a combined spinal and epidural, where we use needle through needle technique, where we reach the epidural space using the epidural needle, and through this we will insert a Whittaker needle, which is a spinal needle, and we reach the cerebrospinal fluid. We give the drug here, come back, withdraw the needle, and then we insert the epidural catheter into the epidural space. Okay, so we can use both the spinal and epidural effects together. So what is this for? Where can we use this? So if the parturient has excruciating pain and if she is not giving you a good position, and if you want immediate pain relief, so we can use combined spinal and epidural, where you can provide opioid into the CSF so that the drug acts very fastly. Within 1 or 2 minutes, the patient will feel comfortable. So that gives maternal satisfaction to the patient. So combined spinal and epidural technique is the most commonly used technique which we use nowadays. Then I told you next technique is dura puncture epidural. So in this dura puncture epidural, the difference is here. See, I told you we'll puncture the dura, but I'm not going to inject any drug into this. Okay, so in order to avoid the adverse effects of the drug into the CSF, I'm avoiding this drug. What are the adverse effects if we give any drug into the CSF? To say we don't have control over the drug. So that will be ascend or descend might happen, and total or hemispinal can happen, or anything can happen. Fetal bradycardia might also occur. So in order to remove these adverse effects, what we have done, we are just puncturing the dura. This is the most common technique used nowadays. Okay, dura puncture epidural anesthesia, most common. It is only being practiced since 10 years. So what do? We are not giving any drug, but why are we puncturing the dura? The dura puncture will create a rent. Okay, that through that rent, it is like we believe that that through the rent, it acts as a conduit for translocation of the drug, which we give in the epidural space. So that I told you, no, that epidural takes 15 to 20 minutes to act, whereas in this DPE technique, it takes only 6 minutes to act. So understood? So why are we performing this? So in order to reduce the duration, we are using this dura puncture epidural technique. So all the techniques are covered, and all the advantages and disadvantages also are covered. Next, going to, so what is she doing? What is she doing? She is in labor and she is happily smiling and walking around. This is walking epidural. She shouldn't be walking around like that. However, somebody has put it on Google so that to advertise it. Obviously, she shouldn't be walking without any assistance. Okay. So before this is nothing but a combined spinal and epidural technique where patients will be walking around. So anesthesiologist has renamed it as walking epidural, but it is same as combined and spinal and epidural technique, where the patient will not be having any motor blockade. So first we have to assess whether the patient is having any motor blockade. So there are some bedside tasks by which we can assess. It is a straight leg raise. First we have to make the patient to sit on the bed and raise both the legs. If she is able to raise the legs, then we can make the patient to sit on the bedside. And if she is able to sit, then make her stand slowly at the bed, and then perform that partial deep bend reflex, partial deep knee bend. So if she is able to perform all this, that means the motor power is intact, and but still assistance should be there while she is moving around. Okay, these are the, now our neuraxial techniques are finished. Now I'll come to the drug. So drug, I told you, we'll give it first initial bolus, and then we'll use the maintenance regimens. The initiation is charging of the epidural, commonly called as charging. So how do we charge? We charge it with local anesthetic along with the opioid. There are so many regimens for this, low doses, that we can deal with it later. Then maintenance of analgesia. There are so many types of maintenance also. The first type is intermittent bolus technique. In this intermittent bolus technique was used when it was used some 50 years before, where they used to give some 10 ml, 10 to 15 ml of local anesthetic. Wait, as Shravanti has told you, when the parturian feels pain, she calls the nurse. Nurse will go and tell the anesthetist. Anesthetist will finish the rounds, we'll have coffee, and then we'll go to the patient. And by then the patient will be having severe pain. Then we'll start assessing sensory, we'll assess motor. By the time we give the drug, all the necessitating pain would be patient would have been gone through. So this is intermittent bolus technique. And also the second bolus, third bolus after we give, there it was noticed that the sacral segments were also blocked and there was intense motor blockade, which is not necessary. So this intermittent bolus technique is not being used now. Now we are using continuous infusion into epidural space, CEI technique. In this CEI technique, in spite of giving the 10 ml as bolus, we have started slowly giving 10 ml per hour as an infusion into the continuous epidural infusion. but as there are no peaks and valleys of local anesthetic, patient will be happily resting. But still, it is observed that it requires larger doses of local anesthetic when we use this kind of a procedure, and the ability to bear down has been decreased, and resulting in increased rate of instrumental deliveries. So this is also not being used now. Now, the next one is patient-controlled epidural infusion, PCEA pumps. As Ravanti has told you, we have been using PCEA pumps into the systemic circulation and also into the epidural spaces. So I'll show you the PCA pump. See, the woman is so happy, smiling, taking the button into charge, taking her pain into control. She feels that she has gained the pain. Psychological advantage of being in control of her own therapy will be there along with the PCA pump. But that's what. But as she told you, there will be a lockout interval. Usually for systemic analgesia, it would be around 3 to 10 minutes. But in this epidural analgesia, it would be around 15 minutes of lockout interval. So in between that lockout interval, we cannot use the demand. She cannot use the demand more. So in order to undergo this, the next technique has come, which is PIEB, Programmed Intermittent Epidural Boluses technique. Here I'll show you in detail. So in this slide, you can see that usually in CEI group, that is combined continuous epidural infusion group, the bolus, the epidural is run at the rate of 5.1 ml per 1.5 hours. So you can see here, there is a bolus is running here, which is 5.1 ml in continuous epidural infusion technique. If I give a demand dose for her, if I tell the patient can press whenever they are feeling pain, it is patient controlled analgesia. She has demanded twice. So this demand bolus has gone 3 ml each. And also patient was very happy with this. Now what we have done is, in spite of giving this as a continuous infusion, we have divided it into 2. And we have given, so for example, I have kept 10 ml as bolus in continuous epidural infusion. Now in programmed intermittent bolus, what I do is, I'll divide the 10 ml into 2, 5 ml each. And then I divide it for every 45 minutes. It is for 1.5 hours. So same as the continuous epidural infusion. But what is the advantage with this? Because of the pressure and because of the amount of the drug we use as a bolus, it is noticed that the spread of the drug is very well circumferential. So the main concept in our drug is it should cover the nerve circumferential. So that is the main concept here. So in continuous epidural infusions, the drug spread would be there, but it will not be circumferential due to the pressure issues. Understood? So in bolus technique, what happens, as we give with pressure, the drug circumference would be covered properly, and then the patient will be very happy with this programmed intermittent boluses. See here, there is no background infusion running over here. There is only programmed intermittent boluses. So later on, what they have done with this programmed intermittent boluses, they have clubbed patient controlled analgesia. So in middle, if patient wants, she can demand the bolus. See here, they have it has 5.1 ml has gone, and again she has demanded the bolus. So 3 ml has gone. Again the programmed intermittent bolus has come. So here you can see if they are nearby. For example, now patient has demanded the bolus has gone, but the next intermittent time has come. So there is a lockout. This would be skipped. The programmed intermittent epidural bolus would be skipped because of the lockout interval, as I mentioned earlier. Did you understand now? So because of this, what is the advantage is the bolus volume is decreased. The total drug dosage was decreased with PIEB, and there was more maximum maternal satisfaction was observed with programmed intermittent boluses technique. And the background infusion rate, lockout interval, patient controlled bolus volume, all this can be manipulated by the anesthetist. Okay, and how do we manipulate it? We manipulate depending on the VAS scoring. If VAS scoring is less than 4, that means patient is happy, satisfied with the analgesia what you are providing. If it is more than 4, what do? We immediately go to the next regimen and we improve our strategies so that the patient will be having a good analgesic effect and VAS score improves. Okay. Next, most sophisticated thing which I have seen is, I also don't know this till I have read this article. This is computer integrated patient controlled infusion. So here what they do is, we have computer is taking over everywhere. So this has taken over this too. Now what happens, for example, in the CSE technique, we'll give fentanyl plus ropivacaine or whatever it is in the cerebrospinal fluid, and then we won't be running any infusion. So if the patient demands the dose, the demand dose will go, which is 5 ml, and there is a lockout interval of 10 minutes. Then this computer will assess what is the demand of the patient. So the demand of the patient is 5 ml. So in the background, the infusion rate will change to 5 ml per hour. Okay, if there is no demand from the patient in the next hour, that 5 ml will continue. But if the demand from the patient is there, second demand of the patient is there, then again what the computer will do, it will change the infusion rate to 10 ml per hour. Did you understand? Because the demand is more from the patient side. So it has increased. So because of this, we need not assess the level. We need not see whether the lumbar is covered or the sacral is covered or what is not covered, or whether the thoracic is also covered, whether we have to decrease the volume or what. So we need not worry about all that. The computer is doing its work and it will change the demand for 3 times. Even though if the patient presses she demands for the 4th dose, what happens? The computer will stop the infusion and it will give the alarm that the patient is not satisfied with even the 3 demand doses, and increase of the infusion rate to 15 ml. 15 ml is the maximum limit, no? So it will give a alarm so that we can switch over the regimen to the next regimen, which is higher dose of the ropivacaine with fentanyl. Okay, understood? This is the most sophisticated technique which we are using now. So these are some of the regimens. I will not go into detail. These are the complications. Most common complication is failure. So because of the epidural space has septations and all, it will not be covered completely in some patients. There would be some patchy block. Only one side of the uterus will be covered, second side will not be covered. So those are the most common. So some troubleshooting is required, which will be done by the anesthetist. Next complications are PDPH, nerve damage, epidural abscess, meningitis, hematoma, fetal heart rate abnormalities like bradycardia, pruritus. All these are there, but it is very less. You can see that the percentage is just 5% and all, which can be dealt easily. Then we can divide the complications into immediate complications and delayed complications. I told you the most common immediate complication is total spinal or high spinal, as we are giving it with spinal, combined spinal and epidural. So most common complication is higher total spinal block, because of which there might be hypotension and there might be convulsions and patient might have cardiac arrest also. If that local anesthesia enters into the vein or artery, it will be there will be a last local anesthesia systemic toxicity, and that too is very, very serious complication. What are the delayed complications? Delayed complications are PDPH, transient backache, urinary retention, epidural hematoma, abscess or meningitis. Some patient might be having permanent neurological damages too. So PDPH, which is most common, second most common complication, which is observed within 24 to 72 hours after the dural puncture, and which is post-dural in nature. As I told you, Tauhi needle will be using, so the needle will be very large bore, just 5 minutes more. So because of that, what happens? The rent will not be closed easily. So we have to close that rent with epidural blood patch. There is no other go. So immediately when the patient complains of PDPH, we have to go for the epidural blood patch shot. Okay, the second next common complication is nerve damages. And once we thread the epidural, no, the epidural catheter might turn around the nerve. As it is a blind procedure, we don't know the fate of the catheter. So it might entangle the nerve and the nerve might get damaged. Okay, when we go through the, so that nerve damage can be seen. Infection rates, which is very, very less. Actually, epidural abscess and meningitis are not that frequent, but they are also the complications seen. Epidural hematoma, actually this is also very uncommon, but because of the engorged epidural veins in the pregnancy, hematoma might happen and it can compress the nerves actually. So just we have to relieve the hematoma. We have to go to the spine specialist where they will be removing the hematoma and the nerve compression signs will be relieved. Backache, this is a myth that so many people tell after epidural we are having a backache, but that backache is not because of your epidural, dear, please. It is very short term. It will be only for 5 to 7 days, and it is due to the local inflammation caused due to the puncture, not more than that. Then maternal fever, as you all know, local anesthesia will raise the temperatures, right? It will cause vasodilation and it will raise the temperature. So maternal fever is also observed, but it is not associated with any neonatal sepsis or anything. So there is no need for unnecessary interventions and unnecessary screening and evaluation of neonatal for sepsis. And if the patient has undergone, parturient has undergone epidural analgesia. Bladder dysfunction. So it is common that if we use epidural for more than 6 hours, obviously the patient might land up into bladder dysfunction. So it is better we catheterize the patient and we just relieve the bladder distension. That is the most appropriate thing to do. Then according to NICE guidelines, there is the best available evidence is that indicates that it is not that labor analgesia is not associated with a longer first stage of labor. So many people think that it will prolong the first stage of labor and the risk of cesarean deliveries are more. But according to NICE guidelines, there is no association of epidural catheterization with the prolonged first stage of labor. But yes, second stage of labor might be prolonged and there might have chances of instrumental delivery. Might be there. Okay, that is the reason we are using very, very, very low concentrations of local anesthetics, which is 0.0625%, which is very minimal. Our main aim is only to provide analgesia, so we give most doses of opioid with lesser doses of local anesthetic. And oxytocin should be used to augment the labor when required. Maternal pushing in the second stage of labor, if possible, to be delayed until the presenting part is visible or until 1 hour after reaching full cervical dilatation. I don't know about this. The obstetric anesthetist have given this line in the in Indian Journal of Anesthesia, so I don't have any idea about this. Next, breastfeeding. Breastfeeding is not a concern, as we all know that breastfeeding immediately benefits are more compared to the disadvantages. So we should encourage the mother to breastfeed immediately. But there are few controversies regarding this breastfeeding, that if a patient has undergone any neuraxial technique and opioid, it should be delayed for 2 to 3 hours. But there is no evidence for this. And then after doing all this also, if your patient come and tells you that she is not satisfied, what might be the reason? So you have done all this, you have already integrated computer into your analgesia, man. But still the patient will feel that I am not happy. There is no maternal satisfaction. The problem is with your mu opioid receptor. You should tell that. Your problem is with your mu opioid receptor because of their polymorphic mutation in the SNP gene, which is at 304A adenine guanine. You cannot tell all this to the patient, but you have to just tell. In some patients that doesn't work like that. So you can just tell like that. And I have seen in few articles that the aberrant pathways will be there, which will make still the patient will be having pain even after adequately blocking lumbar and sacral. So there will be few aberrant nerve pathways which are responsible for that, which are yet to be seen. So personal pharmacology should be there. Personalized medicine. Do you have any idea about personalized medicine? So you should know which patients needs what according to the genes, according to the mu receptors, according to the efficacy and potency. We can make a personalized schedule for each and every patient. This we will be seeing it very soon with artificial intelligence, and artificial intelligence is going to give you, this is the drug regimen for this patient, this is the maximum opioid you can use for this patient. This is going to happen within 10 to 15 years down the lane. So let's wait for that. My conclusion is modern epidural techniques and medications have resulted in more consistent, predictable, and effective analgesia during labor. Recent innovations in drug combinations and delivery systems has resulted in a flexible technique that meets the needs of most of the participants in safe and effective manner. Use of very low concentrations of local anesthetics, when it combines with the lipid-soluble opioids, it does not impede the progress of labor or depress the newborn. The addition of patient-controlled epidural analgesia and innovations using new technologies enhances the patient's satisfaction. So on this note, these are my references. My references maximum are from Gupta madam. She is obstetric anesthetist in Rajasthan. She is one of the leading obstetric anesthetists. And also from Dr. Gurudat sir, my favorite. He is HOD from Mysore Medical College and from Mysore. And these are the other books which I used as reference. So we should thank, I should thank Ravati madam and Arvind sir and Ramarao sir for giving me this opportunity. And I thank my head of the department, sir, and Ashok sir for giving me this opportunity. And thank you all. I hope you have understood little bit of neuraxial techniques. I hope my anesthesia people have understood at least about neuraxial techniques. Thank you all. Thank you. Actually, it's a class for them. I have covered almost all the techniques, but drug regimens I have not covered, madam. Drug regimens is still a very deeper topic which need to be addressed actually in our class. And I already told you this is a subspecialty actually. There is a 1-year course which we cannot be covered, which cannot be covered. So all the best for labor analgesia, everybody. For anesthetists, it is like a cake actually. It is like a cake. We all will be doing so many neuraxial techniques and general anesthesia in our OTs. So it is not different from that. The point is we have to have a deep sensation inside us that we have to provide. That is our duty to provide a painless field of wherever the anesthetist is there. On this note, I end this session. Thank you all. Thank you.
Thank you, ma'am, for your valuable insights, enlightening presentation. Your comprehensive explanation of the topic and the highly interactive approach made the session both informative and engaging. We greatly appreciate the valuable knowledge and practical insights you shared with us today. Now, I kindly request Dr. Arvind sir, Professor of our Department Obstetrics and Gynecology, to kindly present our token of gratitude to Dr. Srija, ma'am. Our next speaker is Dr. V. Ramarao sir, Emeritus Professor, Department of Obstetrics and Gynecology. He'll be speaking about fetal maternal monitoring for safe childbirth during labor analgesia. I kindly request you to take over, sir.
So much laboriously have dealt this painless labor. And what I can talk, I should not pain you much. So, the thing is, why there is pains for labor? If you go to Bible, God has created everything, and He has created Adam and Eve, and He has given Eden gardens and asked them to enjoy. Both of you enjoy everything, but don't eat one fruit. But Satan has come and tempted Eve. No, if you eat this fruit, you will become more than a god. Adam, no, God has prohibited, we should not eat. No, he's telling like that. So finally, because any male has to accept the female words, he has taken this apple. Then God has seen, he became very angry, and he came to know who is the cause for this. Then he cursed the Eve, you bloody lady, because of this it has happened. You will get this labor pains. Your generation will get labor pains. That is cause. Now, we are all talking against nature. What is the womanhood, motherhood? Motherhood is nothing but two factors. Becoming a mother is she should have pains, she should deliver, she should nurse the baby. She has to lactate the baby. These two things will give utmost pleasure in getting a motherhood. So this is the thing. We don't want pains, we don't want breastfeeding. We are doing all nonsense. So, but majority opinion will prevail. See what has happened, once all the lady organizations has gone to Brahma. So what is this nuisance? All these days we are getting labor pains. We don't want this nuisance. Let the men will have this labor pains. So okay, granted. The Brahma has granted labor pains. So the man is getting pains. Some incidences are there when the husband is not getting, the bystander is not getting, the neighbor. Then that so many incidences happened. They again gone to the God. Sir, we want our labor pains back. We'll have labor pains. So this is the story. So like that, see, we cannot change the story and history, whatever you say. But another thing is, since afternoon we are hearing pharmacological agents, non-pharmacological agents, and other so many things we have had. So many surveys have done 2 years back. They have conducted one survey. They counseled all the pregnant ladies well in advance for vaginal delivery. Finally, they could see that cesarean rate is very much reduced. So what I want to say is, counseling we are not giving. There is no time for you to give counseling. So the delivery, 280 days, she is pregnant. At least she will come 10 times with you. How much time you are spending, how much time you are counseling. If you are going on giving counseling, something can do. And what is the primary aim, object of this epidural? To reduce the operative deliveries. So that deliveries you can reduce. Anyhow, not only you have to consult the mother, grandmother also very, very important, we are forgetting. This grandmother is also very, very important. This grandmother is the nuisance for us. ఏమ్మా 10 మందిని కన్నావు కదంటే ఆ రోజులు వేరు సార్, పిల్ల తట్టుకోలేకపోతుంది, చేసేయండి సార్. సో గ్రాండ్ మమ్మాస్ డిస్ట్రెస్. సో దీస్ ఆర్ ఆల్ ద సమ్ ఆఫ్ ద థింగ్స్. దో ఇట్ ఈస్ అవుట్ ఆఫ్ మై దిస్ టాపిక్. ఎనీహౌ యూ హ్యావ్ డిసైడెడ్ ఫర్ ఎపిడ్యూరల్. సో నెక్స్ట్ ఈజ్ పెళ్ళి అయిపోయింది, నెక్స్ట్ తంతు నాది. So feto-maternal monitoring for safe childbirth with labor analgesia. So you have decided, for patient is decided, you have decided. So how to monitor the mother and child? That is the duty now. Next. The object of maternal this thing is early detection of maternal hypotension. That is more important. So the moment epidural or spinal is giving, you have seen the face of an anesthetist is restless. Why? Because at any time she is going to hypotension. Then assess adequacy of analgesia, monitor respiratory and cardiovascular system, identify complications of neuraxial blockade, ensure fetal well-being through continuous surveillance, facilitate timely obstetrical and anesthetic interventions. This is the first objective of the monitoring. Next is so parameters for to be monitored are maternal blood pressure. Very, very important. Why you have to blood pressure? Because most of the time she will go into hypotension. So the commonest complication following epidural anesthesia is hypotension due to sympathetic blockade. This is very, very important. That is the reason why you have to give at least 1 liter of preload. I think 4 years back, we lost one patient. He gave anesthesia and he has attended another case. Patient has hypotension, we lost this patient. So monitoring is baseline BP before epidural placement every 5 minutes or for first 15 to 20 minutes after initiation or top up, then every 15 to 30 minutes during labor. This is the importance of BP recording. Then what is the significance? Hypotension may lead to reduced uteroplacental perfusion, fetal bradycardia, maternal nausea and dizziness. How to manage this? This left lateral tilt. So if there is no left lateral tilt, what they are doing, they are giving a wedge because to keep this. Then preloading of IV fluids, that will always important. Then vasopressors, then oxygen if required. Then maternal heart rate, that is also important. Baseline pulse, continuous or intermittent monitoring, detects hypotension, vasovagal episode, drug-related effects, arrhythmias. A sudden tachycardia may indicate pain, anxiety, and intravascular injection of local anesthesia. Then respiratory rate and oxygen saturation. That is very, very important. Third point. Particularly important when opioids are used epidurally. Combined spinal epidural techniques. Check your respiratory rate, SpO2. Watch for respiratory depression, sedation, hypoxemia. Respiratory monitoring is essential when neuraxial opioids are administered. Level of consciousness. So, is it alert? Orientation, sedation score, we have to see. So, early detection of excessive opioid effect, local anesthetic toxicity, hypoxia. Pain assessment, that is also important because we are doing a painless thing, Visual analog scale, numerical rating scale, these are all very, very important. Maintain effective pain relief, ability to cooperate during labor, minimal motor block. There should not be any motor block in this. So, ideal labor epidural provides analgesia while preserving maternal participation in delivery. This is the analog. So, both the things. Then, motor block assessment. So, our aim is she should also walk. That is called Brome score. What is Brome score? So 0 to 3. 0 means full movement. So, that is ideal. 1, unable to raise extended leg. 2 is unable to flex knee. 3rd is complete block. So this is the important thing. That is called a Brome score. Then this is the thing, Brome score. So here full flexion. 1 is just able to move. 2 is able to move feet only. The 3rd is unable to move feet. This is the important Brome score. Then detects excessive neuraxial block, high neuraxial block, risk of falls and impaired mobility because it is this thing motor is infected. She will fall. Then she will injure. Potential delay in pushing during the 2nd stage of labor. That is important. So monitoring is baseline assessment before neuraxial block, reassess after epidural initiation and after each top-up dose, periodic evaluation throughout the labor. Maintain minimum or no motor block, Brome 0 to 1. Effective analgesia with preserved mobility. Excessive motor blockade may indicate the need for dose adjustment or reassessment of epidural catheter position. Temperature. So she's already told why temperature will be increased. Another thing, epidural anesthesia is associated with maternal pyrexia. So how frequently she is getting pyrexia? Every 4 hours or as per the institutional protocol. Significance, differentiate epidural fever from infection, prevent unnecessary neonatal sepsis and evaluation. Then classification of complications 1, 2, 3. 1 is maternal complications, maternal hypotension, motor blockage, pruritus, nausea, vomiting, urinary protection, shivering, fever. These are all already covered. Then neurological complications are post-dual puncture headache, higher total spinal block, nerve injury. Then infectious complications are epidural abscess, meningitis, then hemorrhagic complication, epidural hematoma. These are all the sum of things. Then drug related. Some drugs they have given, what are the drug related, any complications are there? Local anesthetic toxicity, manifestations are CNS, circumoral numbness, tinnitus, seizures, cardiovascular, that is called arrhythmias, cardiac arrest. Treatment is airway support, lipid emulsion therapy. Opioid-induced respiratory depression, risk factors, intrathecal morphine, high opioid doses requires close monitoring and naloxone if necessary. Obstacle, what are the obstacle complications? So now we have seen the maternal complication. Prolonged 2nd stage of labor, increased instrumental vaginal delivery, failure of anesthesia, analgesia. Fatal complications are fatal bradycardia, fatal heart rate anomalies, and neonatal respiratory depression. Rare catastrophic complications are total spinal anesthesia, cardiac arrest, epidural hematoma, epidural abscess, permanent neurological injury, and anaphylaxis. Incidence of extremely low with proper patient selection. Objectives of intrapartum fetal monitoring. Now, the fetal monitoring, how to assess? Assess fetal oxygenation. Detect fetal hypoxia and ischemia. Monitor fetal response to uterine contractions. Guide obstetric interventions. Ensure safe administration of labor anesthesia. Reduce neonatal neurological injury. Continuous fetal heart rate monitoring remains the cornerstone of the intrapartum surveillance, especially in women receiving neuraxial analgesia. So during labor, uterine contractions temporarily reduce uteroplacental blood flow. Excessive hypoxia results in fetal acidosis, myocardial depression, neurological injury. Labor analgesia may affect these compensatory mechanisms indirectly through maternal hemodynamic changes. So methods of fetal monitoring is intermittent auscultation with the fetoscope or handheld Doppler. So this is the limitations are very this thing. Next is electronic fetal monitoring. So this is the electronic fetal monitoring. You can continuously monitor ultrasound transducer, tocodynamometer. These are all the things you can also uterine contractions you can do. Then you can monitor whether the baseline fetal heart rate is there, variability, accelerations, decelerations, contraction pattern also we can see. Then fetal heart rate interpretation, normal is, so if it is 120, 160, variability is reflect fetal autonomic nervous system integrity, absent SS. So variability reflects. So then decelerations, early decelerations, fatal head compression, variable deceleration, cord compression, late compression due to placenta. These are all the some of the things. So NICHD 3-tier classification, that is called National Institute of Child Health and Human Development. So first category is normal, second category is intermediate, third category is abnormal. Labor analgesia and fetal monitoring. Why continuous monitoring is important is after neuraxial analgesia, maternal hypotension reduces the uteroplacental perfusion, fetal bradycardia, and combined spinal. This is the important thing. So monitoring of the during after epidural, and after epidural. Monitor maternal vitals and maternal hypotension, and monitor 2 to 5 minutes bradycardia. Management of abnormalities after labor analgesia, maternal position change, left lateral position, correct hypotension, with IV fluids, vasopressors, oxygen administration, stop oxytocin if necessary, procolytics, these things are there. Next. Recent advances, physiological CTG interpretation, artificial intelligence, these are all eye centers. Roll up painless labor program. So this is the painless labor. When you are advocating not only the pharmacological agents, so other agents also, if you are using, as I already told you, your success will be more. Your success will be more. You take the consultations with the patient, with the in-laws, with grandparents, then you can also use the physiotherapy models also for reducing this. So with this, you can see so you can achieve good results with painless labor epidural anesthesia. Okay, thank you.
Thank you, sir. We sincerely appreciate the way you beautifully explained and comprehensively covered this crucial aspect of intrapartum care. Your clear discussion on maternal and fetal monitoring, occupied with practical clinical insights, greatly enhanced our understanding of ensuring safety during labor analgesia. Thank you for sharing your expertise, sir. Now I request Dr. Shravanti ma'am, Assistant Professor, Department of Anesthesiology, to kindly present our token of gratitude to Dr. Ramarao sir.
Uh, at last, my turn came. I don't think I will take a more time. Only 10 minutes time only I will take. I'll make it fast. This side. Actually, it's my thank you very much for the opportunity given to me. It's my privilege to invite all of you for this program of that. Now half of the hall is vacant. Before it was so many people are there. Actually, childbirth is the most significant part of the event of the woman's life that everybody knows. In the olden days, no nothing, no labor analgesia, no cesarean section, nothing. They were simply delivering like that, 3 to 4. They were not telling anything. They were telling, oh, delivery was very simple, nothing like that. Nowadays, the ladies have come. The modern ladies have come. Their attitude towards vaginal delivery is changing. They say they are too posh to push. So that is what is happening. They are too posh, they push. They are preferring cesarean section because of tocophobia and because of the pelvic floor relaxation, they think it is. And also they're preferring some time. A time means some muhurtam, something like that is coming. They made a survey in India, 30% of the cesarean sections because of tocophobia. And also almost nearer 25% of cases are due to muhurtam. They are making it, this one. And so in spite of so many advances they are coming, but still normal labor remains the normal remains the cornerstone of the safety of the safe motherhood. That's what. So, and appropriate if you give labor analgesia, they'll have a normal delivery, they'll have a normal life, everything. So labor analgesia plays an important role. States like Karnataka, what they're making is they are integrated the labor analgesia as a part of the this one. I just want to tell you. Idedi slide change avendiki vache ikkada. Sorry. Labor pains can be intense, but safe methods are available to reduce the labor pain during childbirth. So that is nothing but the labor analgesia. Epidural analgesia is most effective. The patient will wake up and she will go childbirth. So like any other medical these procedures, the labor pains are serious. Sometimes some mild complications, sometimes serious complication will occur. It's a patient's choice. What the patient wants, whether the patient wants labor analgesia or something else, it all depends upon patient choice, and the decision will be made by the patient only. And so it's not, but the labor analgesia is not used frequently. What is the reason? Because of many barriers at multiple levels. They are there. So what are the different barriers? The barriers are patient related, healthcare provider related, institutional related, and socio-economic factors related. To overcome these barriers, we have to rectify some of the problems at multiple levels. We will do that. So what are all the patient related? The patient related barriers are lack of antenatal counseling. So that's what is lacking most of the cases, lack of antenatal counseling and a lack of awareness. The people know they don't have any awareness about the anesthesia, lack of awareness, labor analgesia, pain relief and all, childbirth and all, they don't know about that awareness. And a lack of knowledge about that. And inadequate explanation. So in a busy life, we don't have any time to talk to the patients clearly. What is labor pains, how to overcome these pains and all. We don't have time. They just come, they write the prescription, send the patients away. So that's what we are making for them for this case. And important thing is language barrier. Exactly, many people, they don't know English. They only know the local language only. That local language, we cannot talk many of the medical terms. Language is a barrier. And that's one important thing is misconceptions and misconception అంటే అపోహలు చాలా ఎక్కువ ఉంటాయి, మిస్కన్సెప్షన్. దే డోంట్ నో అబౌట్ ద. అండ్ వన్ మోర్ డ్రాబ్యాక్ ఈస్ దే డోంట్ నో వాట్ ఆర్ ఆల్ ద డిఫరెంట్ లేబర్ available methods of pain options and all. They don't know. So that also has to be rectified. And fear of side effects. Many people know there is so much of afraid of anesthesia, afraid of this one. They're so much anxious. They say if you give a epidural or some anesthesia, they maybe get paralyzed, or maybe they may think about backache, and also they think that will be harmful to the baby. That's what they think. And the cultural and religious beliefs. The cultural religious beliefs are the people know labor pains are always natural. One should get the labor pains and deliver. So that is the attitude of them. And fear that analgesia may increase likelihood. Many people, they think if you give anesthesia, definitely induction also they don't accept the people. If you give induction, they land into cesarean section. If you give analgesia, land into cesarean section. That's what the people they'll have this one. And ignorance because of lack of education and reluctance. So many things are there, and they're very ignorant, even undergo anything, any of labor analgesia or etc. anything. And institution system resources, shortage of trained staff. So what is happening? Not only the patient side, the institution also the same. Shortage of trained staff. The trained staff are not there. If you ask any sister, if you ask ourselves also, even we don't know completely of the details of the things of labor analgesia. We have to be get trained. Anesthesia services around the clock also not available because of shortage of staff, shortage of even OB-GYN doctors also shortage, anesthesia shortage, and nurses also shortage. Many people are shortage are there. And shortage of equipment. That is the thing. Recently, we have started bringing all the equipment that is needed for that. Shortage of staff is there. And the drugs. Even drugs also not available. Maybe anesthesia people must be knowing. The drugs, even drugs also, the properly is not available. Drugs are not available. And monitoring facilities for the patients also is not available. So many things. And no standard protocols for labor analgesia so far it is established. So we are planning to make it. We are planning to make some SOPs for that. And financial constraint. If you make an order now, after many months on also, the drugs don't come, equipment don't come, because of financial constraint, additional cost of analgesia, and all that will be there. And lack of insurance coverage. That is the main thing. If you tell the patients Orgasry means, they'll come forward running to the hospital. If you tell no insurance means, nobody will come forward. So lack of insurance services also one of the reasons also that is there. And communication barriers. Communication barriers means here what is happening is poor communication between the healthcare providers. We are the one healthcare providers. We are the doctors. We are the one healthcare providers. And also between the healthcare providers and pregnant ladies, there's no proper communication regarding antenatal counseling. We are not giving, and not removing the misconceptions and myths also, and not removing the fear and anxiety in the patient. All these things, we are the one, because of lack of communication, we are doing that. How to rectify all the barriers? How to rectify all the barriers? Because we have to give a proper antenatal counseling. That's important. Antenatal education is important for them, and preferred language. Whatever the language we give, only the preferred language means either English or local language, Telugu or Oriya language, because the other people also they're coming many. So preferred language, not only for the antenatal mothers, but the partners and the family members. We have to give the proper counseling. When to start the counseling? We have to start the counseling at least as early as possible. Regarding many aspects, we can interact with the patients. Not only that, we have to strictly follow that counseling at 28th to 36th week of the pregnancy. We had to. And a non-technical, simple language. The counseling should be in a simple language, non-technical, local language. We have to make it, if possible, visual aids have to be used for them. Visual aids have to be used them. And we have to put some videos also to them, health education videos. And also we have to give some pamphlets, and the family members, we have to involve the family members in the counseling. and we had to correct the fears and misconceptions what they have got. Remove the anxieties for them, remove anxieties about pain and the medication effects on the baby. We had to reassure them these medicines will act on the mother only, they don't have an effect on the baby. That's what we had to tell them. If they got anxious about that, we had to remove the anxiousness and take childbirth classes. Childbirth classes have to be taken, explaining them what is pain, what is analgesia, how to get rid of that, what are the different methods and all. We had to tell them, tell the benefits and risk. Tell the because we had to tell the benefit of the vaginal delivery and the risk of the cesarean section. All these things we had to explain them, and available methods and all we had to explain them, and we had to correct the misconception, and pain management options if they are there, we had to tell them, explain them. And also we had to reassure the mother and relatives, and epidural doesn't cause any long backache or any delayed breastfeeding and all. We had to tell them, and tell them there is a dedicated obstetrician 24/7 is available, anesthesia is available, other nurse explain staff is available. We had to tell them, explain the benefits of calm and controlled birthing will reduce the stress hormones that can potentially stall the labor. That's what we have to tell. And good doctor-patient relationship has to be maintained, and informed consent in a in an understandable local language, we have to take that one. And also what is needed for that, or for OPs and all, we need a counseling room. Counseling room we definitely needed, must be attached to the OP. All the patients and natal mothers who are coming, they have to attend the counseling room also. Dedicated counselor has to be there. He must be a doctor, he must be a postgraduate level, that's enough for making a counseling. And physiotherapy has to be there. And ASHA workers also have to sit with them in the counsel room to counsel, because many patients know they will listen to the ASHA workers than us. So they have got a more belief on ASHA workers also. So they have to be there. And the posters have about non-pharmacological methods. We had to pharmacological methods. All these things we have to display in the counseling room, so that the people they can see, they can watch, they can come to, they'll be impressed looking at that one. And posters of prenatal exercises, if at all they are there, it has to be posted in the walls. If available, return. We available, give a written educational materials for them, and for them making a decision of that. Explain all the available different methods, non-pharmacological and pharmacological methods. I think they have told already. I don't have to touch again this one. Breathing, relaxation, movements, position, hydrotherapy and all. The physiotherapists have explained us well, very well. And also pharmacological options, our anesthesia team completely, totally, they have explained everything very well. And the regular training of the staff, that's important. Here we have to make the regular training of the staff. Time to time they have to have the training. And regarding classes have to take, and orientation and sensitization of the midwives and nurses, the doctors and PGs have to be done time to time. Similar like that of the CM is what we are conducting now, time to time. And develop standardized labor analgesia protocols, improve multidisciplinary collaboration. So there must be coordination between the obstetrician and anesthesiologists and physiotherapists and midwives and nurses. The multidisciplinary, the coordination, cooperation has to be there, and it has to be covered under the insurance, public health programs. The government has to take action regarding this one. And also dedicated labor analgesia services should be available round the clock. Increased training staff has to be available in the labor rooms, and the dedicated faculty to make in charge of labor analgesia unit. She is the one taking complete the responsibility of totally supervising what are all the activities that are taking place, and make available all the essential drugs which are important for this process. Institutional policies. What institutional policies? Some rules and regulations have to be framed by the institution, like our GEMS hospital. They have to make some, that is, make availability of the labor analgesia availability, and make it accessibility. It should be accessible, and our hospital should give a facilities for antenatal counseling room education, and they have to make the schedules about the teaching programs of this antenatal counseling and all they have to make, and also standardized protocols also the hospital has to make that one, that with the consultation of the anesthesia department, the epidural combined spinal epidural inhalation or opioid, other non-pharmacological methods and all they have to tell with the consultation of the physiotherapist and all. They have to make some protocols for this case. Monitoring of safe standard method they have to make. Multidisciplinary informed consent have to be there. Proper documentation and record keeping and all have to be there. And quality assurance has to be this one. The audit has to be done. Quality assurance have to be done. Regular review of the utilization rates and all we have to see. And also we have to cross-check the maternal neonatal outcome, whether the patients are satisfied or not. We have to check the quality. If we have to make the corrections, if any problem comes, gaps come, we have to try to rectify. And we try to possible give a respectable maternity care. Overcoming economic barriers include labor analgesia and government mental health programs like insurance coverage, cost-effective medications and all we have to use, and increase public funding. Public funding has, because public people, they are coming, they are constructing. Some example in the Kakinada, there is there. SRMT block is there. SRMT people, they came forward, they have constructed, they have built a big maternity block. Something like increased public funding from the health, for the sake of health services. They have to come forward, they have to donate for the funding and all, they have to make this one. And what are the myths? How to explain the myths in Telugu? So all these myths and all, we have to explain them in Telugu. Myths are very common. Even educated people also, they have got lot of myths are there. And there are cultural, social myths, and medical myths common in the rural areas. We can see these myths. And and many patients, they fear. So many myths are there for them. And there's lots of discouragement and blocking the process because of myths only. They are not coming for the labor analgesia and all. We have to make the plans to counter all these myths they are having, and to use antenatal counseling and ASHA training and staff teaching and all we had to make. So what action we had to take to overcome the myths? And because make Telugu pamphlets, make the pamphlets in Telugu to clarify their myths and facts, and print the slogan as follows. So slogan, this type of slogans we had to print and keep everywhere in the hospital. We are keeping also in the labor room. There is, you can read that. Meeku telusa neppu lekunda sahaja prasavamu. నార్మల్గా పురుడు కలిగే సదుపాయం ఇక్కడ కలదు. శ్రీకాకుళం జిల్లాలో వేరే హాస్పిటల్లో కూడా ఇటు లేనటువంటి అద్భుతమైన అవకాశం మీరు ఉపయోగించుకునేందుకు ఈ క్రింది వారిని సంప్రదించండి అని దే పుట్ ద నేమ్స్ ఆల్సో. వీ హ్యావ్ టు మేక్ దీస్ పోస్టర్స్ ఇన్ ద hospital everywhere. In the labor room there are 2 or 3 are there. In the outside also, antenatal OP also there are there. Like this they have to make. And also we have to make this type of posters also. We have to ప్రసవ నొప్పి భరించడం అసలైన తల్లి యొక్క గొప్పతనం, సురక్షితంగా సంతోషంగా కనడం మీ యొక్క హక్కు అన్న ఈ టైప్ ఆఫ్ పోస్టర్స్ we have to place them there in the hospital, so that the people will read that, they'll be get impressed looking at that one. And also some of the doubts the patients will have, all these, because we are making the pamphlets in Telugu. In the pamphlet Telugu we have to print all these things in Telugu local language. The people, they can read, and they will have some clarification of the doubts. Epidural anesthesia అంటే ఏంటి? ప్రసవ నొప్పి సురక్షితంగా తగ్గించే ఆధునిక పద్ధతి, నడుములో చిన్న ఇంజెక్షన్ ద్వారా మందు ఇస్తాము అన్నది వాళ్ళకి చెప్పాలి. వాళ్ళ బోల్డ్ ప్రశ్నలు వస్తాయి, బోల్డ్ డౌట్లు వస్తాయి. కొత్తది ఏమన్నా మనం ప్రవేశపెట్టామనుకోండి, వాళ్ళకి చాలా డౌట్లు వస్తాయి. ఆ డౌట్లన్నీ క్లియర్ చేయవలసిన బాధ్యత మనకే ఉంది. సో దట్ వీల్ ఎంకరేజ్ అవర్ బిజినెస్. We had to make that one. And one more, so many questions they will make that. Noppi పూర్తిగా తగ్గుతుందా? They'll get so many people, they'll get a doubt. నొప్పి పూర్తిగా తగ్గుతుందా లేదా అని. We had to tell the answer is చాలా వరకు తగ్గుతుంది. నొక్కుడు వచ్చినప్పుడు మాత్రం తెలిసేలా ఉంటుంది కాబట్టి మీరు పుష్ చేయగలుగుతారు అనే మాట మనం చెప్పాలి వాళ్ళకి. అంటే ఎప్పుడు అడగాలి, ఎప్పుడు అడగాలి. నొప్పులు మొదలైన తర్వాత సర్విక్స్ 3-4 సెంటీమీటర్స్ ఓపెన్ అయిన తర్వాత మేము లేబర్ రూమ్లో అడగండి. అప్పుడు వాళ్ళు అర్ధరాత్రైనా అనస్థీషియా టీం రెడీగా ఉంటుంది కాబట్టి జాబ్ ఈస్ ఫర్ యూ. అనస్థీషియా టీం రెడీగా ఉంటుంది కాబట్టి దే విల్ గివ్ దాట్. అండ్ బిడ్డకి ప్రమాదం అన్న క్వశ్చన్ వాళ్ళు అడుగుతారు. చాలా ప్రశ్నలు. కాదు, బిడ్డకి ప్రమాదం కాదు, బిడ్డకి ఎటువంటి హాని జరగదు. పైగా తల్లి నొప్పి టెన్షన్ తగ్గితే బిడ్డకు కూడా చాలా మంచిది అన్నది వాళ్ళకి అన్ని ప్యాంప్లెట్స్ మనం పంచాలి. దీంట్లో ప్యాంప్లెట్స్ తయారు చేసి మన బుక్ తెలుగులో నడవగలరా, కొంతమందికి డౌట్ వస్తూ ఉంటుంది, మేము నడుస్తామా లేదా, నడవగలమా లేదా అని చెప్పేసి. వాళ్ళకి అవును, తక్కువ డోస్ మందు ఇవ్వడం వల్ల కాళ్ళు పూర్తిగా మొద్దు బారవు, మీరు నడవచ్చు, టాయిలెట్కి కూడా వెళ్ళవచ్చు అన్నది వాళ్ళకి చెప్పాలి. వాళ్ళ డౌట్ క్లియర్ చేయాలి. సిజేరియన్ అవుతుందా అని చెప్పేసి కూడా వాళ్ళకి డౌట్ వస్తూ ఉంటుంది. అప్పుడు ఏం చెప్పాలంటే ఎపిడ్యూరల్ వల్ల సిజేరియన్ అవకాశం పెరగదు, కర్ణాటక రాష్ట్రం నొప్పి భయం తగ్గించి సిజేరియన్ తగ్గడానికి ఇదే వాడుతుంది అన్నది ఇది వాళ్ళకి దాంట్లో ప్రింట్ చేసి ఇవ్వాలి. సైడ్ ఎఫెక్ట్స్, కొందరికి సైడ్ ఎఫెక్ట్స్ అంటూ ఏమి ఉండవు. కొందరికి ఏమవుతుందంటే వణుకు జ్వరం కొంచెం రావడం తగ్గుతుంది, బీపీ తగ్గడం జరుగుతుంది. కానీ అది వెరీ వెరీ రేర్ దట్ వీళ్ళక్క తలనొప్పి నొప్పి 100లో ఒకళ్ళకి వస్తే రావచ్చు అన్న సంగతి చెప్పాలి. అపోహ, వాళ్ళకి చాలా అపోహలు ఉంటాయి. అపోహలు, మిత్స్ అండ్ ఫ్యాక్ట్స్ వి షుడ్ బి ఏబుల్ టు ఎక్స్ప్లెయిన్ దట్. ఎపిడ్యూరల్ వల్ల జీవితాంతం నడువు నొప్పి వస్తుంది అన్నది అపోహ కలుగుతుంది వాళ్ళకి. అలాంటప్పుడు నిజం ఏం చెప్పాలంటే వెన్నుపోటు వల్ల జీవితాంతం నొప్పి శాస్త్రీయంగా రుజువు కాలేదు. కాన్పు తర్వాత నడువు నొప్పి ఎపిడ్యూరల్ తీసుకున్నా వస్తుంది, తీసుకోకపోయినా వస్తుంది. నిజం ఏంటంటే గర్భం వల్ల బిడ్డను ఎత్తుకోవడం వల్ల మాత్రమే నడుము నొప్పి వస్తుంది కానీ ఎపిడ్యూరల్ వల్ల రాదు అనే అపోహ వాళ్ళకి క్లియర్ చేయాల్సిన బాధ్యత మనకుంది. వెన్నుపూట చేస్తే పక్షవాతం వస్తుందా? 2 లక్షల మందిలో ఒకరికి మాత్రమే ఇలాంటి సమస్య వస్తుంది. less than the risk of dying in a road accident if done by trained anesthetists with aseptic precautions. So there's nothing, no paralysis, nothing will occur. అది కాదు, అలా మనం ప్రింట్ చేసి పేపర్స్ పంచాలని చెప్పడానికనే చెప్తున్నాను. ఎపిడ్యూరల్ వాళ్ళ బిడ్డకి మత్తు ఎక్కుతుందా? ఎక్కదు. మేము ఇచ్చేది తక్కువ డోస్ కాబట్టి తల్లి నొప్పితో టెన్షన్ పడితే బిడ్డకే హాని ఏమీ జరగదు. ద బేబీ ఈజ్ మోర్ ఎఫెక్టెడ్ బై మదర్ స్ట్రెస్ హార్మోన్ దాన్ ద పెయిన్ రిలీఫ్. దట్స్ వాట్. అండ్ ఇంకొక అపోహ ఏంటంటే, ఇంకో మిత్ ఏంటంటే ఎపిడ్యూరల్ తీసుకుంటే నార్మల్ డెలివరీ కాదు, సిజేరియన్ అవుతుందని చెప్తూ ఉంటారు. కాదు, ఎపిడ్యూరల్ తీసుకుంటే 95% ఆఫ్ పీపుల్కి నార్మల్ డెలివరీ అవుతుంది. ఓన్లీ సెవరల్ స్టడీస్ they said there is no increase in cesarean section rate. It is reduced by reducing exhaustion. Because of exhaustion, mothers are affected. And because of reducing exhaustion, the forceps rate also only 5 to 10% of cases, but baby is safe, better. అండ్ మేము పుష్ చేయగలమా అని డెలివరీ అడుగుతారు. ఎస్, మోడర్న్ లో డోసెస్ ఆఫ్ ఎపిడ్యూరల్ దే కెన్ పుష్. దట్స్ వాట్ వీ హ్యావ్ టు ఎక్స్ప్లెయిన్ దమ్. నొప్పులు ఇవ్వగలరు, పుష్ ద ఫీల్ ప్రెషర్. రెండో దశలో మందు ఇస్తారు కాబట్టి మీకు నొక్కుడది తెలుస్తుంది, పుష్ చేయగలరు అన్నది మనం ఒక ప్రింట్ చేసిన వాడిని పేపర్స్ దాన్ని పెట్టాలి. ఎపిడ్యూరల్ ఫెయిల్ అయితే నొప్పి వస్తుంది, నొప్పి భరించలేను అని చెప్పినప్పుడు మనం success rate is 95% of the cases. The people they're nothing like failure. 95% of the patients ki idi panchestundi, they will deliver. Pani cheyipothe ఒకవేళ తీయపోతే మళ్ళీ వేస్తాము అన్నది వాళ్ళకి ఎక్స్ప్లెయిన్ చేసి చెప్పాలి. వేడి నీళ్ళలో కూర్చుంటే బిడ్డ నలుపు అవుతాడా అన్నది వాళ్ళకి అపోహ ఉంటే కనుక there is నిజం ఏంటంటే no scientific basis that with the temperature 37 degrees the same as body, the skin color is genetic. అంతేగాని వాటర్లో డెలివరీ అయిన వాళ్ళని వచ్చింది అని చెప్పడానికి లేదు. సో యూజ్ ఆశా వర్కర్స్ who have seen the water birth to speak the villages. ఎపిడ్యూరల్ తీసుకుంటే పాలు రావు అన్న అపోహ కూడా వాళ్ళకు ఉంటుంది. అది తప్పు. నిజం ఏంటంటే నో ఎఫెక్ట్ ఆన్ ద లాక్టేషన్. ఎర్లీ స్కిన్ టు స్కిన్ టచ్ ఫీడింగ్ ఈజ్ ఎంకరేజ్ విత్ ఎపిడ్యూరల్. సో ద పేషెంట్స్కి బ్రెస్ట్ ఫీడింగ్ నార్మల్గా ఫస్ట్ అవర్లోనే వాళ్ళు చేస్తారు అనేది చెప్పాలి. తర్వాత ఏమో భర్త హస్బెండ్ను అత్తగారు ఒప్పుకోరు. ఫ్యాక్ట్ ఏంటంటే ఇన్వైట్ ద ఫ్యామిలీ పీపుల్ ఫర్ ద కౌన్సిలింగ్. యూ ఇన్వైట్ దెమ్, సిట్ విత్ దెమ్, counsel with them, not just a patient. Involve the husband, mother-in-law and all antenatal counseling. If we show 10 minutes of video for them, then really they will accept all these things. Second stage lo సెకండ్ స్టేజ్లో డజన్ ప్రొలాంగ్ డెలివరీ ప్రొలాంగ్ అవుతుందా అని చెప్తూ ఉంటారు. కానీ అది నిజము కాదు. నిజం ఏంటంటే లో డోస్ ఎపిడ్యూరల్ డజన్ ప్రొలాంగ్ ద సెకండ్ స్టేజ్. దట్స్ వాట్. ఓకే. అండ్ డబ్బున్న వాళ్ళకి మాత్రమే ఇది, పేదవాళ్ళకి కాదన్న అపోహ కూడా వాళ్ళలో ఉంటుంది. నిజం ఏంటంటే నార్మల్ ప్లస్ ఎపిడ్యూరల్ ఖర్చు 15,000 అవుతుంది, సిజారన్ అయితే 25,000 అవుతుంది. నొప్పి తగ్గితే హాస్పిటల్ ఉండే 2 రోజుల్లోనే వెళ్ళిపోవచ్చు అన్నది వాళ్ళకి చెప్పాలి. 15,000 ప్రతి రోగికి ఎపిడ్యూరల్ ఇస్తే మా పని పెరుగుతుంది. ఉండండి, ఇది వాళ్ళకి ప్రతి రోజుకి ఎపిడ్యూరల్ ఇస్తే మా పని పెరుగుతుందని అనస్థెసిస్టులు భావిస్తారు. అప్టేక్ విల్ బి ఓన్లీ 20 to 40%, ఇనిషియల్ నాట్ 100%. It reduces emergency LSCS in the middle of the night. They don't have to come and go for the Caesar. So one epidural prevents one cesarean section at the middle of the night at 2 a.m. The role ఇది యాక్చువల్లీ తెలుగుకి ఎలాగ వాళ్ళకి ఓవర్కమ్ దేర్ మిత్స్ అండ్ బిలీవ్స్ అండ్ ఆల్, వీ హ్యావ్ టు మేక్ అ ప్రింట్ అండ్ వీ హ్యావ్ టు డిస్ట్రిబ్యూట్ టు ద పేషెంట్స్ సో దట్ దే కెన్ అండర్స్టాండ్ దట్. రోల్ ఆఫ్ ద అబ్స్ట్రిషన్ టాక్ అండ్ వీడియో ఫర్ ద మిస్ అండ్ ఫ్యాక్ట్ ఫర్ 5 minutes ఆర్ 1 minute. ప్రసవ నొప్పి అంటే చాలా భయపడతారు, కానీ ఇప్పుడు మన శ్రీకాకుళం ఇస్ అవైలబుల్గా ఉన్నదని ఒకటి మనం చెప్తాం. రోల్ ఆఫ్ అనెస్థిస్ట్ ఆల్సో దే హ్యావ్ టు టాక్ 1 minute వీడియో. ఎలా చేస్తారు, ఏం చేస్తారు, ఎలా ఇస్తారు, కాళ్ళు తెలుస్తాయి, నడవగలరు, పుష్ చేయగలరు, ఖర్చు మాత్రం తక్కువే అవుతుంది అన్న సంగతి వాళ్ళకి చెప్పాలి. ఇన్స్టిట్యూషనల్ పాలసీస్ మేక్ లేబర్ అనల్జీసియా అవైలబుల్ ఇన్ ద hospital, accessible. Arrange antenatal counseling education. SOPs and documentation have to be made. Record keeping. Informed consent, both the languages, Telugu, local language, they have to make. And it doesn't carry, unko sangat manam cheppali valaki, it doesn't carry epidural. 100% of painless, doesn't carry 100% of painless. They need up, sometimes they need top up also. Sometimes very rarely it may land into this one, we have to see. And standardized protocols, so drugs and equipment should be made available, and monitoring safety methods have to be there. And quality assurance and చెప్పేసాను కదా. Take home message is labor pain is a real deserves treatment. No woman should suffer unnecessarily pain. Lack of awareness is a major barrier. Safe for the both mother and the baby when appropriately administered. Every woman should be aware of the different options and pain reliefs, and also this one. So multidisciplinary approach has to be there. Our aim is to sensitize everyone, all the doctors and nurses here, to have this one so that the future will, because the future they will be learning about labor analgesia, they will apply the methods of a labor analgesia so that the reduce the incidence of cesarean section can be reduced. That's what make the woman, no woman should suffer with the labor pains. That is the future aim and future slogan. We'll see how much we'll succeed in getting this procedure, because this is a new procedure we are making it. I hope we'll be successful in making this procedure well, and make the childbirth as a sweet and memorable event in their life. Thank you very much for the opportunity given to me.
Thank you, ma'am, for the concise and crisp talk on the topic The way you addressed the barriers, explored practical solutions, and motivated us to work towards wider acceptance and accessibility of labor analgesia was both enlightening and empowering. Now I request Dr. Srija ma'am, Assistant Professor, Department of Anesthesiology, to kindly present our token of gratitude to our HOD ma'am, Dr. Revati ma'am. As we come to the end of today's CME, I request Dr. Sri Lakshmi, my fellow PG, to kindly deliver the vote of thanks.
Good evening, respected Dean Dr. Lakshmi Lalita ma'am, Medical Director Dr. Hemant sir, Academic Director and Medical Superintendent Dr. Sudhi sir, esteemed speakers, faculty members, colleagues, postgraduates, interns, and dear participants. As we conclude this enlightening CME of labor analgesia, it's my privilege to propose the vote of thanks. I sincerely thank our respected Dean, Dr. Lakshmi Lalita ma'am, for her constant encouragement and support towards academic excellence and continued learning. My heartfelt gratitude to Dr. Hemant sir and Dr. Sudhir sir for their valuable guidance and for gracing this occasion with their presence. A special note of thanks to our head of department and organizing chairperson, Dr. P. Ravati ma'am, whose visionary leadership, dedication to maternal health care, and commitment to academic excellence were instrumental in organizing the CME. Her efforts to promote evidence-based practice and safe motherhood continue to inspire us all. I would also like to specially acknowledge Dr. Arvind sir, whose vision, initiative, and tireless efforts laid the foundation for today's program. His dedication and hard work played a key role in transforming his idea into a successful academic event. I sincerely thank all the faculty members, postgraduates, interns, and participants for their enthusiastic participation and active interaction. A special word of appreciation to organizing committee, technical team, administrative staff, and supporting personnel for their dedicated work behind the scenes. Thank you all. Have a pleasant evening.